cystitis. What is it? Is anybody? Inflammation. Dacro का मतलब होता है lacrimal sac. Cyst का मतलब होता है sac. Okay, so dacryocystitis is nothing but infection या inflammation of the lacrimal sac or the lacrimal apparatus as a whole. ठीक है. What is the first line management of the given child? Now they have directly given you the diagnosis that the child is suffering from dacryocystitis. उसके लिए I hope all of you are quite aware. Okay, this here you can see. I hope this was a recent question. You all are quite aware of that. Where is lacrimal gland located on which wall of the orbit? Lacrimal gland is located on which wall of the orbit? It is located on the lateral wall of the orbit. Please remember this was the recent question. Okay. So lateral wall of the orbit पे होती है lacrimal gland. It produces tears. Those tears travel via all the way to the eye. It provides a tear film. And then these tears are absorbed by the lacrimal apparatus. These tears are absorbed by the lacrimal apparatus. And on the medial side, on the medial wall, we have what? On the medial wall, we have the punctum. The punctum, upper punctum and lower punctum, which will connect with the canaliculi. Upper canaliculi and lower canaliculi. They will connect and form the common canaliculi. This common canaliculi will dilate and form the lacrimal sac. And then finally it will open as the nasolacrimal duct. In which meatus? In the inferior meatus. Okay? So that is what is the lacrimal apparatus. So if they ask you, lacrimal sac is located on. So lacrimal sac is located on the medial wall. Don't get confused with this. This was a straightforward question this time. Okay, so lacrimal gland is located on the lateral wall, but lacrimal sac, which is responsible for absorption of tears, is located on the medial wall of the orbit. No issues with this? That's important. Okay. Chalo, so this is a case of dacryocystitis, and I hope all of you are quite aware. If the child is less than 1 year of age, okay, if the child is less than 1 year of age, definitely the mode of management will be mode of management will be a regular sac massage. The mother will be advised that she has to do a gentle massage over the lacrimal sac so that all the fluid which is there, it will be drained. क्यों? Problem क्या होता है? क्यों होता है lacrimal sac का inflammation? Because the opening of the nasolacrimal duct into the inferior meatus, that usually gets blocked. And जब वो block हो जाएगी तो tears drain हो पाएंगे क्या? नहीं हो पाते. So all the tears will remain inside the lacrimal sac. And पानी भी अगर एक जगह जमा होता है तो वो भी गंदा हो जाता है. Just like that, the tears remain stagnant. They remain standstill for a longer period of time. Therefore, they get infected. And that's the reason why the patient develops dacryocystitis. Okay. So that's the reason why we need to drain the tears which have been accumulated. Therefore, we ask the mother to do a gentle, regular sac massage over the lacrimal sac. If the child is less than 1 year of age. If the child is between 1 to 4 years of age, then syringing and probing is required. That means we will insert a syringe or a needle in the punctum and will push saline into it so that with the pressure, all the tears are drained properly. And if there is any blockage over here, that gets relieved. Last, if the child is more than 4 years of age or in any adult, definitely the treatment of choice is DCR, that is dacryocystostomy. This is a surgery which is done, and stomy is what? Making a new opening, making a new mouth. That means the nasolacrimal duct normally opens into the inferior meatus. Now we will make a new opening for it into the middle meatus. Reason being because middle meatus is wider, therefore chances of blockage will be much lesser. Okay? So this was also been a question. Please remember the new opening for nasolacrimal after dacryocystostomy is done in which meatus? Answer should be middle meatus. कोई दिक्कत नहीं है. For that, this was a previous year question again. This instrument which is given over here, it is used for which surgery? So this is nothing but the Kereson's punch, or we can call it as the DCR punch. This is usually used for the dacryocystostomy surgery. No issues with this, anybody? Please remember the instrument as well. So what should be your answer now? As the child is 3 years of age, your answer should be option B, syringing and probing. Okay? So, question number 152 now. A 60-year-old woman comes to the emergency department due to sudden onset, severe pain in her left eye with blurred vision, nausea, vomiting. The symptoms began a few minutes ago while she was watching a movie, okay, in a theater. Her temperature is 36.8 degrees Celsius, normal. Blood pressure is 140 by 90 millimeters of mercury, high normal. Pulse rate is 82 beats per minute and respiratory rate is 14 breaths per minute. On examination, it shows, it reveals there is decreased visual acuity. Okay, examination reveals there is decreased visual acuity. Her left eye appears red with a hazy cornea, shallow anterior chamber, dilated and a fixed pupil. Her left eye is stony, hard to touch. What is the most probable diagnosis? Important is shallow anterior chamber is a keyword. Stony hard eyeball is a keyword. Okay. So I hope you, if there is a shallow anterior chamber they have mentioned, that means agar anterior chamber shallow hai, the chances of blockage of the anterior chamber are very, very high. Therefore, normally the aqueous humor which is there, it will not be drained. If the aqueous humor is not drained properly, why? Because anterior chamber se drain hota hai na. What are the two mechanisms? Majority drains by the trabecular meshwork and 10% outflow is by the uveoscleral pathway. Okay? But as the anterior chamber is narrow, definitely the aqueous humor will not be able to drain. Agar wo drain nahi kar pa raha, there will be increased pressure of aqueous humor in the anterior chamber. And when there is increased pressure of aqueous humor in the anterior chamber, that will ultimately lead to increased intraocular pressure. I hope all of you are quite aware. There is a classical triad: increased intraocular pressure, optic nerve defect, and visual field defect. These three together characterizes glaucoma. Okay, glaucoma is not only increased IOP. जिसको लगता है वो दिमाग से निकाल दो. That is intraocular hypertension if rest of the things are normal. This is the glaucoma. That means when there is increased intraocular pressure plus optic nerve defect plus visual field defect. Okay, so that has to be remembered. Now, definitely she is a woman. Usually, glaucoma which is there can be of two types. Glaucoma can be a open angle glaucoma or it can be a angle closure glaucoma. Important is open angle glaucoma usually कब होता है? Angle तो open है, but फिर why the aqueous humor is not able to drain? I hope now the voice is fine. Please remember, angle तो open है, but क्यों नहीं drain हो पा रहा? Because the trabecular meshwork is blocked. Why it is blocked? Usually, primary open angle glaucoma can be due to because it is blocked because there was fibrosis. Age के साथ क्या हो सकता है? The trabecular meshwork जो है, there would have been fibrosis of the trabecular meshwork. Due to that fibrosis, due to that sclerosis, therefore the aqueous humor is not able to drain. ठीक है? So usually old age में होता है, it is due to fibrosis of the trabecular meshwork. Okay? Whereas secondary open angle glaucoma जो होता है, वो young patients में हो जाता है. And young patients में what is the reason for blockage then? In young patients, the reason for blockage can be anything which is blocking the trabecular meshwork. It can be blood also, that is hyphema. Blood in anterior chamber is known as hyphema. So definitely that blood can block, definitely, okay? That blood can block, or it can be a case of cataract, where what has happened? कौन सा cataract होता है वो? Morgagnian cataract. Morgagnian cataract में क्या होता है? There is liquefaction of the lens. And जब liquefaction हो जाता है lens का, तो क्या हो जाता है? The proteins which are there of the lens, they will come out, and these proteins will block the trabecular meshwork, due to which the aqueous humor is not able to drain. That can also lead to an open angle. No issues with this, and this is more common in males. Whereas if I talk about angle closure glaucoma, it is more common in females, that to middle-aged or elderly females. And important is angle closure glaucoma, mein definitely the angle is very narrow. It is very shallow. Okay. And it is measured by anybody? Angle is measured by gonioscopy. Please remember, this was the previous year straightforward question. Okay. Angle is measured by gonioscopy itself. Please remember this. No issues with this. So please remember, these are the types of glaucoma. So यहाँ पे definitely our patient is a young woman. And open angle glaucoma जो होता है, it is gradual in onset. धीरे धीरे develop होता है. The patient will never come to us in emergency usually. ठीक है? Emergency में जो आता है, it is a case of angle closure glaucoma itself. So usually here the patient has come to ED with sudden onset severe pain in her left eye. There is blurring of vision, nausea and vomiting. Along with that, there is a trigger factor. What was the trigger factor? She was already watching a movie. ठीक है? Apart from that, you can see there is decreased visual acuity. The visual field defects are definitely present. Her left eye appears red Okay, there is congestion of the left eye. Can you see? The left eye appears red. There is haziness of cornea. There is a hazy cornea. And most important, can you see the pupil which is there? It is, there's a classical term that you use. और ये जैसे ही term use होती है तुम्हारा diagnosis बन जाना चाहिए. Fixed, non-reactive, mid-dilated, vertically oval pupil. That's the classical case of angle closure glaucoma. Okay, fixed, non-reactive, mid-dilated, vertically oval pupil. Okay, so fixed, non-reactive, mid-dilated, vertically oval pupil is seen in cases of acute attacks of angle closure glaucoma. So here definitely, what should be the answer? It should be an acute attack of angle closure glaucoma, which can also be called as acute congestive glaucoma. तो उसी को ही बोला जाता है acute congestive glaucoma. क्यों congestive? Because there was so much of pressure, because aqueous humor was not able to drain. There was so much of pressure. Due to that, the patient has developed sudden signs and symptoms. Okay, therefore it is called as acute congestive glaucoma. And this is a keyword, that the pressure is too much. If you try to palpate, or if you try to touch the eyeball, it feels like a stone. It feels like a rock. So either they will say stony hard or rocky hard eyeball. That is a characteristic feature associated with angle closure glaucoma. No issues with this, anybody? Please remember, open angle glaucoma, I've told you, it does not present in emergency usually. Okay? Acute hemorrhagic conjunctivitis. In hemorrhagic conjunctivitis, the patient will not have a mid-dilated pupil or a stony hard eyeball. Anterior uveitis, what is the characteristic feature of anterior uveitis, anybody? In anterior uveitis, the most characteristic feature are these. What are these? These are nothing but the anterior uveitis. Uveitis is what? Inflammation of the uvea. Okay, right? Important is, whenever there is inflammation, there will be inflammatory cells. Okay, these inflammatory cells, they will come and they will get stuck behind the inner surface of cornea. Okay, these inflammatory cells will get stuck in the on the inner surface of cornea, and these are called as keratic precipitates. The most characteristic feature which is associated with anterior uveitis are these keratic precipitates or the inflammatory cells. Can you see these keratic precipitates are aligned, have aligned themselves in a triangular fashion? Therefore, this triangle is what is called as the Als triangle. Okay, this is called as the classical Als triangle. Along with that, can you see this pupil also? This pupil which is there, you can see this is irregular pupil. This irregular mid-dilated pupil is what is called as, anybody? Festooned pupil. Very good. So this irregular mid-dilated pupil is known as a festooned pupil. It is due to formation of what? Adhesions or synechia. ठीक है, तो चिपक जाती है. Iris, usually, please remember, the iris gets stuck to the lens, okay, or the iris gets stuck to the cornea, and due to that reason, definitely this irregular mid-dilated pupil is formed. That is nothing else but festooned pupil. It is due to formation of synechia or formation of adhesions. ठीक है? So that's important. Apart from that, recent FMG question again. Now, in a case of anterior uveitis, we will also see classical nodules. And what are these nodules called as? The one which is present at the base of the iris. The one which is present at the base of iris is known as the Busaka's nodules. Okay, the one which is present at base of iris are known as Busaka's nodules. Whereas the question which has been asked was this: the one which is present at the pupillary margins. कोने पे है ना, तो कोने पे आर द कोपेज नोड्यूल्स. बेस पे बुसाकास, कोने पे कोपे. ठीक है, तो pupillary margins पे the nodules which are present are known as the Coppé's nodules. So these are the characteristic feature. Keratic precipitates, arched triangle, festooned pupil, Busaka's nodules, Coppé's nodules. None of them has been present over here. And in a case of anterior uveitis, the patient will complain of redness vagara, but more important, the patient will complain of extreme pain as well. There can be other inflammatory signs also. Okay? No issues with this, anybody? Most common cause of anterior uveitis is idiopathic. Please remember. What is the drug of acute? Is for acute angle closure. Acute है ना बच्चों, acute है तो तुम्हारा main aim ये pressure कम करना है ही नहीं. Pressure कम करने में time लग जाएगा. Main aim is to break the attack. And why? How are we going to break the attack? The pupil is dilated. I try to constrict the pupil. As you constrict the pupil, definitely the attack will be broken down and the patient will have relief of pain. क्यों? क्योंकि pain क्यों हो रहा है? Because your ciliary muscles are in spasm. Okay, so that's the reason you need to relax them, and that is what is done by pilocarpine. So pilocarpine, which is a parasympathomimetic drug. Okay, parasympathomimetic drug. कौन सी agonist होती है वो? M1, M2, M3, M3 agonist. ठीक है, तो M1 stomach, M2 heart, M3 all other sites. Usually M3 agonist होती है वो. That is usually given to break the attack. But if they say drug of choice for only angle closure glaucoma, not acute attack of angle closure glaucoma, not acute congestive glaucoma. Drug of choice for only angle closure glaucoma maintenance के लिए. एक बार break हो गया attack, उसके बाद क्या दोगे? तो उसके बाद definitely we will give mannitol. उसके बाद डेफिनेटली द मैनिटोल विल बी द ड्रग ऑफ चॉइस. कोई दिक्कत नहीं है, दोनों में डिफरेंस समझ में आ रहा है. acute attack of angle closure glaucoma, also called as acute congestive glaucoma, उसमें primary aim is to break the attack, so give pilocarpine. But maintenance phase of angle closure glaucoma, over there we will give mannitol because it will help in decreasing the pressure. In acute attack also we will give mannitol along with acetazolamide along with glycerol, but that will not be the drug of choice during acute attack. That's the basic. No issues with this. Drug of choice for open angle glaucoma. It will be prostaglandin analogs. Prostaglandin analogs, something like latanoprost, bimatoprost. Okay, so these are usually the drug of choice for an open angle glaucoma. Okay, and these two drugs, pilocarpine and latanoprost, are absolutely contraindicated during. Very good. They are contraindicated during a case of anterior uveitis. दो बार का question है ये, ठीक है? Because both of these drugs will cause inflammation. These are pro-inflammatory drugs. So already in uveitis, the patient is having inflammation. Do you want it to increase further? No. That's the reason why if a patient of anterior uveitis is having increased intraocular pressure, we will not give two anti-glaucoma drugs like prostaglandin analogs like latanoprost and pilocarpine. इसके अलावा कुछ भी दे दो. You can give beta blockers also. You can give acetazolamide also. You can give other anti-glaucoma drugs, something like apraclonidine also. But don't give these drugs. Apraclonidine is contraindicated in which age group? Children, because they cause sedation. Please remember, apraclonidine, brimonidine, these are the drugs which are contraindicated in children because they cause sedation. That's the basic. Question number 153 now. It says a 40-year-old patient came to OPD with symptoms of excessive sleepiness and lethargy all the time. On physical examination, the clinical features depicted in the image were seen. Per abdominal examination shows no free fluid in the abdomen. So there is no ascites as such. Liver and spleen are not palpable. Okay, there is no hepatosplenomegaly also. He gives history of regular alcohol consumption. What is the most probable diagnosis? What is seen in the image? First of all, what does the sclera shows? Yellowish discoloration of sclera, that is known as icterus. Okay? So yellowish discoloration of sclera, that is known as icterus. That is suggestive of jaundice in the patient. Next, what is this? Anybody? It is known as just it is known as clubbing. Please remember, it is known as clubbing. Clubbing में क्या हो जाता है? Definitely parrot beak appearance of nail. Okay, there is a parrot beak like appearance of nails usually, and which angle decreases? Lowy bonds angle decreases. Please remember that is the case of clubbing. Clubbing कहाँ कहाँ होती है? क्या? Cirrhosis, iron deficiency में clubbing होती है, spooning होती है. Boiler में क्या होता है? That's important. COPD में clubbing नहीं होती, यही difference है. This was the question: which among the following disease will not cause clubbing? Answer was COPD. I knew that. What happens usually? इसी की वजह से. So important is COPD does not present with clubbing. That's the most important thing. Clubbing is usually seen in lung cancer. Clubbing is usually seen in bronchiectasis as well. ठीक है? So that's the basic idea. इतनी कम से कम याद रख लो. It is seen in cirrhosis. It is seen in bronchiectasis. It is seen in lung cancer or lung malignancy. ठीक है? So that's the important thing. ठीक है? So please remember COPD में usually the patient does not have any kind of clubbing. ठीक है? Next important is this one. What is this? Anybody? Very good. This is a case of Dupuytren's contracture. Dupuytren's contracture is usually due to fibrosis of the flexor tendon. Okay? When there is fibrosis of the flexor tendon, that causes Dupuytren's contracture. They went one step further in one of the previous FMG exams and they just gave images of palms and they asked what is the diagnosis. So on images of palms, there was redness of palms. That is called as palmar erythema. Redness को क्या बोलते हैं? Erythema बोलते हो ना? So that was the case of palmar erythema. These all together are features of cirrhosis बच्चों. याद रखना palmar erythema, Dupuytren's contracture, clubbing, jaundice, all of these are classical features of cirrhosis itself. ठीक है? So this was August question. Palmar erythema was December question. ठीक है? So both of these have come earlier, and I have told you alcohol, TB, HIV are their hotshot favorites क्योंकि वो इंडिया में common है, basic है. ठीक है? So therefore the diagnosis should be alcoholic cirrhosis in this patient. What is hepatolenticular degeneration? Wilson's disease. In Wilson's disease, we know we have already done a case that over there the patient will not only have hepatic features, the patient will also have damage to the lenticle, that is the basal ganglia. The patient will develop which disease-like features? Parkinsonism-like features. So none of them have been present over here. Okay. Next is portal hypertension. In cases of portal hypertension, definitely they have said no free fluid abdomen. Important is portal hypertension is also a complication of cirrhosis itself. But important is that portal hypertension, whenever pressure inside portal vein increases, what will happen? The fluid will be kicked outside also, no? So that will lead to ascites. But they are saying no free fluid in the abdomen. That means chances of portal hypertension are very, very, very less likely in the condition. Okay? Budd-Chiari syndrome is a hepatic vein thrombosis. Okay? Again, when there is hepatic vein thrombosis, again the pressure in the hepatic vein will rise, and that will also lead to ascites in the patient usually. No issues with this. Apart from that, अगर hepatic vein का thrombosis होता है, all the blood remains in the liver itself. क्यों? क्योंकि it is not able to go outside. It is not able to drain into the inferior vena cava. तो पूरा का पूरा blood कहाँ pull up हो जाता है? लिवर के अंदर. तो यहाँ पे क्या बोला उन्होंने? लिवर एंड स्प्लीन आर नॉट पैल्पेबल. बट यूजुअली अगर पूरा का पूरा ब्लड लिवर में कंजस्ट हो रहा है तो द साइज ऑफ द लिवर शुड इंक्रीज. इट शुड बी हेपेटोमीगली. इज इट मेंशन्ड ओवर हियर? नो. So that's the basic idea. ठीक है? तो Budd-Chiari syndrome is nothing but hepatic vein thrombosis. ठीक है? No issues really anybody. Important is most common cause of cirrhosis is nothing else but alcohol. There can also be some of the non-alcoholic causes of cirrhosis. Most important among them is NASH, that is non-alcoholic steatohepatitis. Apart from that, other causes can be Wilson's disease. Other cause can be hemochromatosis. Other cause can be alpha-1 antitrypsin deficiency. One of the causes can also be Budd-Chiari syndrome. Other cause can be extrahepatic portal vein fibrosis. There can be multiple other causes of cirrhosis also in a patient. Please remember that. Okay? But important is how to differentiate between an alcoholic hepatitis and a non-alcoholic hepatitis. Anybody? जल्दी से बताओ यार. बराबर AST by ALT ratio. मैंने बोला था ना, most specific is the AST by ALT ratio, not a single enzyme. AST by ALT ratio, if it is more than 1, that is suggestive of alcoholic liver disease. If it is less than 1, that is suggestive of non-alcoholic liver disease. And when AST by ALT ratio is more than 2, that is diagnostic of alcoholic liver disease. अब दूसरा कुछ करने की भी जरूरत नहीं है. It is diagnostic of alcoholic liver disease. ठीक है? तो please remember that. No issues with this. Agar AST by ALT ratio is not in the option, then the single best answer should be AST itself. Okay? Because ALT is more specific marker of non-alcoholic. It is a main specific marker of non-alcoholic liver diseases. Okay? Please remember something like viral hepatitis. Okay? So uska agar marker पूछा जाता है, that is ALT. No issues with this. That's important. And what is the marker of bile duct pathologies? Very good. It is serum ALP, that is alkaline phosphatase. So if they are talking about raised alkaline phosphatase, you need to think there is some problem in the bile duct. That means it is which kind of jaundice? Obstructive or a post-hepatic jaundice then. ठीक है? So that's important. ये तुम्हें clear करेगा. These are the keywords. क्योंकि jaundice हर केस में होगा. Hepatomegaly या ये बाकी सब चीजें हर केस में होगी. These are the important keywords which will tell you कि pathology है तो है का. ठीक है? Next is question number 154. Okay. And usually the patient is started on steroids in cases of alcoholic cirrhosis. And definitely the best treatment is liver transplant itself. Question number 154 states, a young woman presents with complaints as shown below, which is triggered when she immerses the extremities in cold water. Episodes usually affect the fingers and toes, along with numbness and pain in the affected areas. There is no underlying illness or comorbidity in the patient. Comment on the diagnosis. Now, important is this is what definitely we are able to see color changes in the fingers or toes of the female. What are the two important risk factors? I've already told you. One is definitely cold water exposure. और दूसरा जो मैंने commonly बोला आजकल exam के questions में आ रहा है, that is nothing else but prolonged vibration. The two important risk factors are nothing but cold water exposure and prolonged vibration, right? Important after this, usually after prolonged vibration or after cold water exposure, what happens? The small vessels in the fingers and the toes undergo spasm. Okay, अपने आप को relax भी हो जाएंगी, but usually they undergo spasm. Okay, so spasm of the arterioles as well as the spasm of venules. When both of them are in spasm, there will be no blood supply. Therefore, the fingers will turn white in color. Then what is going to happen? The venules are still in spasm, but the arterioles have relaxed. Now the deoxygenated blood is mixing with the oxygenated blood, and therefore the fingers will turn blue in color. And now when venules will also relax, normal blood flow will be established, and therefore now they will turn red in color. Sequence of color changes have also been asked in Raynaud's phenomena. The sequence of color changes WBR, that is white, blue, red. That has to be remembered. Now we know, okay, this is a case of Raynaud's phenomena. Okay, it is more common in females also. But important is that Raynaud's phenomena can be of two types. Either it can be a primary Raynaud's phenomena or it can be a secondary Raynaud's phenomena. Can anybody tell me what is the difference? किसमें underlying cause होती है? Very good. The primary Raynaud's phenomena has no underlying cause. It is not associated with any other disease. That means it is the cause is idiopathic over here. It is idiopathic over here. Whereas secondary Raynaud's phenomena is associated with which kind of diseases? It is associated with connective tissue disorders. Connective tissue disorders like SLE, scleroderma, rheumatoid arthritis. In patients में होगा even in Sjogren's syndrome at times. ठीक है? So now यहाँ पे क्या बोला उन्होंने classically? No underlying illness, there is no comorbidity. Okay, so there is no underlying illness and no comorbidity. That means the cause is idiopathic. So it should be primary or secondary. Primary Raynaud's phenomena. I hope all of you are quite aware. We have discussed in surgery that primary Raynaud's phenomena can also be called as Raynaud's disease. Okay, याद रखना एक बार. No issues with this. Frostbite is usually not due to cold water exposure. It is due to freezing temperatures. Okay, जब freezing temperatures होता है, there is crystallization or there is ice crystals formation inside the tissue, due to which the blood supply is completely cut off to the peripheries and due to which there is gangrene of the peripheries. That is what is frostbite. Okay, that we know commonly. What is Gottran sign? Gottran signs is usually this. Can you see this rash on the knuckles? This is known as the Gottran's sign. What is this? This rash on the trunk is known as the shawl sign. And what is this? Very good. This rash is known as the heliotrope rash. So these are the classical signs of, very good. So Gottran sign, shawl sign, and heliotrope rash. These are classical signs of dermatomyositis. These are the classical signs of dermatomyositis in a patient. Okay? So please remember this. कोई दिक्कत नहीं है इसमें. That has to be remembered. जल्दी से एंटीबॉडी बता दो अभी चलो. ये क्वेश्चन आता है. एंटीबॉडीज तुम रूमेट में क्या ही पढ़ते हो? रूमेट में बस एंटीबॉडीज इंपॉर्टेंट होती है, बाकी कोई नहीं, बाकी कुछ इंपॉर्टेंट नहीं. Anti-Jo1 antibody is characteristic of dermatomyositis. Please remember, okay? Anti-Jo1 antibody is characteristic of dermatomyositis. जल्दी से बाकी ओके. इसका ड्रग ऑफ चॉइस बता दो. Raynaud's phenomena. It is CCBs. That is calcium channel blocker. That was a previous year question again. Just asked. Raynaud's phenomena. What is the drug of choice? Answer is calcium channel blockers. Drugs like dipins. Okay, nifedipine. Can be given. Amlodipine, nifedipine. Followed by that, if this is not an option, then the second best answer should be nitrates. Second best answer is nitrates. Okay. Important now. Jaldi se bataoge tum. In cases of SLE, which is the most specific antibody? Most specific antibody is anti-Smith antibody. Most sensitive antibody. मोस्ट सेंसिटिव का क्या मतलब, हर पेशेंट में पॉजिटिव होगी, इट विल बी पॉजिटिव इन एवरी पेशेंट, बट व्हाई इट इज नॉट स्पेसिफिक, बिकॉज इट इज सीन इन ऑल अदर रूमेटोलॉजिकल डिसीज ऑल्सो, सब रूमेटोलॉजिकल कंडीशंस में पॉजिटिव आती है ये, एंड दैट इज नथिंग एल्स बट ANA, that is anti-nuclear antibody. So never make your diagnosis based on anti-nuclear antibody, because anti-nuclear antibody is positive in SLE, scleroderma, rheumatoid arthritis, Sjogren's syndrome. बताओ क्या कौन सा डिसीज है? तो इट इज पॉजिटिव इन एवरी डिसीज. दैट्स द रीजन व्हाई इट कैन नॉट बी स्पेसिफिक, इट इज ओनली सेंसिटिव एंटीबॉडी. 98% पेशेंट्स में दिखेगी एसएलई के, बट दैट डज नॉट मीन इट इज वेरी मच स्पेसिफिक. स्पेसिफिक इज ऑलवेज द एंटी स्मिथ एंटीबॉडी, which is the antibody which tells you about the disease activity. Shabash. The antibody which tells you about the disease activity is the anti-double stranded DNA antibody. It is anti-double stranded DNA antibody. The antibody which is responsible for photosensitivity. Very good. So the antibody which is responsible for photosensitivity is anti-Rho antibody. Anti-Rho antibody is also known to cause neonatal lupus. Okay, अगर पेशेंट में SLE है और उसका बच्चा पैदा होता है, okay, please remember anti-Rho antibody, which is the IgG subtype, that will cross the placenta and that will cause neonatal lupus. एक बार क्वेश्चन में neonatal lupus भी आया हुआ है. How the child will present to you? With malar rash, but not over here. Malar rash around the eyes of the child, periorbital malar rash, along with that severe bradycardia and complete heart block. These are the characteristic features of neonatal lupus. क्या क्या होता है? Periorbital malar rash, severe bradycardia and complete heart block. The reason is these antibodies will target his SA node and his AV node. That's the reason why he presents with severe bradycardia and complete heart block like features. ठीक है, so that has to be remembered. No issues with this, anybody? Okay. Neuropsychiatric features, anti-ribosomal P antibody. चलो, anti-neuronal antibody will cause lupus cerebritis, that is brain damage. And okay, anti-histone antibody, very important. Very good. Anti-histone antibody is positive in cases of drug-induced lupus. Drug-induced lupus is caused by, or drug-induced SLE is caused by ship drugs, sulfonamides, hydralazine, isoniazid, and procainamide. Please remember, anti-histone antibody will be positive in case of drug-induced lupus or drug-induced SLE. एक important बात याद रखनी है, that drug-induced SLE will never cause involvement of kidney and brain. Okay, they will not cause involvement of kidney and brain. And SLE में most common or the earliest system to be affected is, क्योंकि SLE is a multi-system disease, it can involve many systems. The most common and the earliest system affected is musculoskeletal system. इसीलिए the most common symptom will be arthralgia, that is joint pain, myalgia, that is muscle pain. इसके साथ आता है patient तुम्हारे पास, ठीक है? Now arthritis is not a diagnostic criteria for SLE. It is only synovitis. Arthritis की जरूरत नहीं है to diagnose SLE. That's the important thing. No issues with this. जल्दी से systemic sclerosis, also known as scleroderma. Investigation of choice. कौन सी antibody? Anti-topoisomerase antibody. Please remember, in systemic sclerosis or scleroderma, it is anti-topoisomerase antibody. Then if I ask you about limited sclerosis or limited scleroderma, limited scleroderma is also known as which syndrome? CREST syndrome. Very good. CREST syndrome, C stands for calcinosis cutis, R stands for Raynaud's phenomena, E stands for esophageal dysmotility, S stands for sclerodactyly, that is spitting on fingers, and T stands for telangiectasia. ठीक है, तो limited scleroderma और CREST syndrome, the antibody is now anti-centromere antibody. It is anti-centromere antibody. कोई दिक्कत नहीं, सॉरी, कोई दिक्कत नहीं है इसमें. प्लीज रिमेंबर, एंड तुम जो एंटी रो एंटी ला कर रहे हो वो किस में दिखती है? एंटी रो एंड एंटी ला एंटीबॉडी. वेरी गुड. इट इज सीन इन Sjogren's syndrome. ठीक है, it is seen in Sjogren's syndrome. Please remember, Sjogren's syndrome is also known as keratoconjunctivitis sicca. Sicca का मतलब होता है dry. तो characteristic features would be dry eye and dry mouth. ठीक है, characteristic features will be dry eye and dry mouth. ठीक है, कोई दिक्कत नहीं है इसमें. So ये antibodies मैंने भी बार बार नहीं पढ़ी. I have read it during my time, but I have read it so well that I remember it till now. यही तुम्हें भी करना पड़ेगा. because antibodies are very important. These are the diagnostic feature. बाकी सब mostly तो symptoms similar होंगे, myalgia, arthralgia, polyarthralgia, polyarthritis, बाकी सब features same होते हैं. Okay, so that's the important thing. Antibody अगर दी गई है तो मतलब वो literally हलवा बना दिया गया है तुम्हारे लिए वो question, क्योंकि अगर एंटीबॉडी दी है मतलब इसके आगे कुछ बचता ही नहीं है ना भाई, और क्या नाम ही दे देते डिसीज का फिर वो. ठीक है, so that's important. Now, moving further, question number 155. A 60-year-old man has presented with chronic projectile vomiting and there is significant weight loss. You are suspecting gastric outlet obstruction. Which of the following electrolyte abnormality is seen in the patient? Now, if you are saying chronic projectile vomiting, जब patient में vomiting हो जाती है, it is also seen in one another condition. यहाँ पे तो adult है. Okay, what is the most common cause of gastric outlet obstruction? That was asked the previous year question. Please tell me that. मोस्ट कॉमन कॉज ऑफ गैस्ट्रिक आउटलेट ऑब्स्ट्रक्शन लिखवा है सर्जरी के नोट्स में. क्या? कार्सिनोमा. कौन सा? गैस्ट्रिक कैंसर. आई हैव टोल्ड यू ना, गैस्ट्रिक अडिनोकार्सिनोमा और गैस्ट्रिक कैंसर इज द मोस्ट कॉमन कॉज ऑफ गैस्ट्रिक आउटलेट ऑब्स्ट्रक्शन नाउअडेज. ठीक है, तो याद रखना ये बात. अदर कॉजेस कैन बी पेप्टिक अल्सर डिसीज, ओके, व्हिच कॉजेस अ टी पॉट स्टमक. ठीक है ना, आर ग्लास स्टमक बोला है ना स्टीनोसिस की वजह से. एंड इन न्यूनेट्स द कॉज कैन बी सीएचपीएस. ठीक है, तो इंपॉर्टेंट इज दैट सीएचपीएस अगर होता है दैट इज कंजेनाइटल हाइपरट्रॉफिक पाइलोरिक स्टीनोसिस, आल्सो नोन एज इडियोपैथिक हाइपरट्रॉफिक पाइलोरिक stenosis. There is hypertrophy of the pyloric muscle that causes gastric outlet obstruction. Important is it will be seen in male or female child. More commonly male child. Will present at birth or after 2 to 3 weeks of birth. After 2 to 3 weeks of birth usually. ठीक है, and the complaint will be projectile vomiting. If the child is presenting after 2 to 3 weeks of birth with non-bilious projectile vomiting, diagnosis is CHPS. If I say the neonate is presented at birth with bilious projectile vomiting, diagnosis is very good, duodenal atresia. That's the basic differentiating feature. ठीक है, यहाँ पे तो definitely it is a case of CH. If I talk about CHPS, usually in CHPS, if I take a X-ray, first line investigation is X-ray abdomen with sign is seen, single bubble sign is seen. And if I perform a barium meal, with signs are seen, it is the mushroom sign. What is this? It is the string sign. And what is this? The shoulder sign. Shabbos. The mushroom sign, string sign, and shoulder sign will be seen on barium meal. But what is the investigation of choice? Barium investigation of choice is ultrasound abdomen because it shows thickness of the pyloric muscles itself. Okay? And treatment of choice is with surgery. Anybody? Ramsted's pyloromyotomy. Now, important is, मैं अगर vomiting की बात करूं, any case of chronic vomiting, what will happen? There will be loss of acid from the stomach. Okay, acid is what? HCl. So there is loss of acid from the stomach, guys. Now H plus and Cl minus are being lost. So as H plus is being lost, the patient will have acidosis or alkalosis. The patient will have metabolic alkalosis. Why? Because H plus ions are acidic in nature, and as they are lost out of the body, the patient will go into metabolic alkalosis. Now Cl minus are lost, therefore the patient will have hypochloremia. The patient will have hypochloremia. Now, as there is metabolic alkalosis in your body, what will the body try to do? The body will try to restore, or it will try to again normalize the body pH. Okay, to normalize the pH now, it should kick out which substances from the body? Alkaline substances from the body, na? Because the body is in alkalosis. Usko agar see, बॉडी से एसिडिक सब्सटेंसेस लॉस हुए इसलिए बॉडी अल्कलोसिस में चली गई है. नाउ अगर अल्कलोसिस से उसको वापस आना है तो इसको किसको बाहर फेंकना पड़ेगा? Alkaline substances को. What are alkaline substances in the body? Bicarbonates. So it has to throw out bicarbonate so that the pH will again come down to normal. So that's the reason why body causes loss of bicarbonates in urine. Body causes loss of bicarbonates in urine. But we know bicarbonates अकेले जाते क्या कभी? नहीं. They always take sodium along with them. Therefore, there is loss of bicarbonates as well as sodium inside the urine. चलो जब तक bicarbonates loss हो रहा है, no problem. But as the sodium is being lost, body goes into hyponatremia. Body goes into hyponatremia. अपनी बॉडी कुछ भी मैनेज कर सकती है, हाइपोनेट्रीमिया नहीं. It does not tolerate hyponatremia. It wants sodium for sure. So as it wants sodium, immediately as the body goes into hyponatremia, body says, no, I will not lose sodium. So as it will not sodium, for that it activates the RAS. What is RAS? Tensin aldosterone system. What is the product of RAS? Aldosterone. And what is the function of aldosterone, buddies? दो काम करता है ना वो. एक, it causes retention of sodium and water. Okay, so that's what we want. It is causing retention of sodium and water. It is keeping sodium and water inside the body itself, and that can cause hypernatremia in the later stages. And along with that, it kicks out whom? It kicks out potassium ions and H plus ions in the urine. तो वो किसको बाहर फेंक देता है? Potassium ions and H plus ions. As potassium ions are being lost, the patient goes into hypokalemia, and as H plus ions are being lost in the urine. Normally तुम्हारी body को H plus ions lose करने चाहिए क्या? नहीं. क्यों? क्योंकि body कहाँ है तुम्हारी? Your body is already in alkalosis. Why? Because we are losing a lot of H plus ions. So it should not lose any more H plus ions, but it is losing H plus ions. तो ये सीधा फंडा है, उल्टा फंडा है. उल्टा हो रहा है ना, उल्टा हो रहा है जो होना चाहिए उससे. तो उल्टा जो होता है उसको बोला जाता है पैराडॉक्सिकल. And what is excreted out in urine? H plus ion. H plus ions in urine are called as acid urea. So now total metabolic abnormality जो हमने डिस्कस की थी सर्जरी में, what is that? Hypochloremic, hypokalemic, sometimes hyponatremic metabolic alkalosis with paradoxical aciduria. करो equate. कहाँ आ रहा है? Hypokalemic, hypochloremic metabolic alkalosis with hyponatremia. Answer is option A itself. ठीक है? This has been twice repeated question of your FMG examination. तो उसके लिए एक बार ये समझ लो, एक बार खुद निकाल लेना. It will become easier. रटने की जरूरत नहीं है कुछ भी. Very easy. हाँ. Paradoxical aciduria, ये देखो. Aciduria क्यों बोल रहे हैं हम इसको? Because aldosterone is kicking out H plus ions in the urine. Therefore, H plus ions are acidic in nature. तो जब acidic substance urine में जाएगा, तो it will be called as aciduria. Paradoxical क्यों? तुम्हारी body कौन से state में है अभी? Alkalosis. So we should lose acidic ions or what? Shall we lose acidic ions? No. क्योंकि already body किस में है? Alkalosis में है. हमें क्या lose करना चाहिए? Alkaline substances. हम lose क्या कर रहे हैं? Acidic substances. तो ये बराबर सीधा फंडा है, उल्टा फंडा है. उल्टा हो रहा है ना जो होना चाहिए उससे, इसलिए पैराडॉक्सिकल. समझे? So that's important. And what is the best fluid to be given? ये electrolyte abnormality होती है ना, इसलिए the best fluid to be given to a patient of CHP should be. मैंने क्या बोला था? The patient will come to you with hypernatremia. The patient will come to you in the later stages. ठीक है? Already उसकी बॉडी में सोडियम अब ज्यादा है, तो तुम नॉर्मल सलाइन देके और हाइपरनाइट्रेमिया भेजना चाहते हो क्या पेशेंट को? मैंने क्या बोला था? इट शुड बी हाफ नॉर्मल सलाइन. 0.45% NaCl शुड बी गिवन टू द पेशेंट. डाइल्यूट करना होता है सलाइन को, प्लस 5% डेक्सट्रोज. क्यों? क्योंकि बच्चे को क्या नहीं मिल रहा? न्यूट्रिशन ही नहीं मिल रहा, खा ही नहीं पा रहा, सब वॉमिट हो जा रहा है. विथ पोटेशियम क्लोराइड. क्यों? क्योंकि पोटेशियम भी कम है, क्लोराइड भी कम है. तो विथ पोटेशियम क्लोराइड, KCl. ठीक है? So that's the best fluid to be given. No issues with this, anybody? We have written that in surgery already, and this was a previous year question. Don't make a mistake over here. Question number 156. A 30-year-old alcoholic had his last drink 48 hours ago. सरकारी क्वेश्चन साइकेट्री का. इसके अलावा क्वेश्चन ही नहीं आता साइकेट्री में. हर एग्जाम, ऑलमोस्ट हर ऑल्टरनेटिव एग्जाम फिक्स क्वेश्चन है ये तुम्हारा. ठीक है? 48 hours ago he develops anger and rage attacks and appears unable to identify the faces of family members. That means, is he oriented to time, place and person or disoriented to time, place and person? He is disoriented to time, place and person. ठीक है? तो एक important feature है disorientation. ठीक है? And can't see inanimate objects. He has been brought to the emergency room. What is your diagnosis? So it is a case of hallucinosis में disorientation कभी नहीं होता है patient में. So please remember, if I talk about alcohol withdrawal, usually alcohol withdrawal कब होता है? When there is a chronic alcoholic और उसको कुछ time से alcohol नहीं मिल पा रही हो. ठीक है? So usually if he has not got alcohol from the last 6 to 12 hours, first of all he'll go in minor withdrawal symptom, and the most common alcohol withdrawal symptom will be Very good. The most common alcohol withdrawal symptom are coarse tremors usually. Okay. Then the patient will also have what? The patient will also have tachycardia. The patient will also have fever as well. Okay. There will be hyperthermia. The patient will also have tachypnea, increased respiratory rate, or there will be dyspnea as well. Okay. So please remember these are the features, but most important are the tremors. These are called as withdrawal tremors or alcohol withdrawal tremors. They present within 6 to 12 hours of the last intake. Usko, he is not given alcohol for the last 12 to 24 hours now. From 12 to 24 hours, he is not getting alcohol. Now he will land up somewhere into alcoholic hallucinosis. Please tell me, they will be auditory hallucinations commonly or visual hallucinations? Commonly, they will be auditory hallucinations. Important is, please remember, in cases of neurotic disorders, commonly they are visual hallucinations. In all other disorders like psychiatric or psychotic disorders, these are auditory hallucinations. ये नहीं बोल रहा कि visual नहीं होंगे. Common are which one? Common or auditory, visual can also occur. Please remember. Hallucinations are what? It is a false perception without a real object or a real stimulus. कुछ नहीं सामने तो भी मुझे साफ दिखाई दे रहा है यहाँ पे. That is what is a hallucination. So the patient will have alcoholic hallucination. Here the patient important. Orientation to time, place and person will be absolutely intact. ठीक है. Patient को पता होगा ये मेरा दोस्त है, मैं कहाँ हूँ, इस बार का time हो रहा है. That he knows. Then definitely after 24 to 48 hours, usually in the like there have been 24 to 48 hours after the last intake. Now the patient will land up into alcoholic withdrawal seizures. तो withdrawal seizures होंगे. कौन से seizures होते हैं patient में? दिख रहे क्या? GTCS, that is generalized tonic-clonic seizures will occur in the patient. ठीक है? And lastly, after 48 hours or 72 hours of the last intake, after 48 to 72 hours of last intake, the patient will land up into delirium tremens, which is the most severe form of alcohol withdrawal. ठीक है? Delirium tremens. Delirium का ही मतलब क्या होता है बच्चों? Disorientation या clouding of consciousness. Okay, delirium means these two important things. Okay, first is disorientation to time, place, and person, and second is clouding of consciousness. That means his consciousness is not intact. I'm not saying he's unconscious, but he is not having an intact consciousness. Okay, so that's important. He's confused. Okay, so disorientation and clouding of consciousness, जैसे ही mention करते हैं, in any case, it is a case of delirium. It is a case of delirium. Please remember. Usually they can also mention a patient who has been admitted in the ICU, अकेला पड़ा है वो, बाकी कोई जा तो नहीं सकता. So he is admitted in the ICU, and usually after 2 or 3 days, he suffers from clouding of consciousness. There is altered sensorium in the patient. He is disoriented to time, place, and person. Okay, and usually his symptoms worsen towards the evening. What is this phenomena called as in the delirium? This phenomena is called as the sundowning phenomena, right? As the day progresses towards the evening, the symptoms of the patient will get worsened. That is the classical phenomena seen in cases of delirium. Okay? So that is the case of delirium usually. Okay? It is an acute onset mental disorder. Acute onset. Most common acute onset mental disorder is delirium. याद रखना है बात. You have to differentiate it from dementia. क्यों? क्योंकि dementia में भी memory loss होता है, इसमें भी memory loss होता है. दोनों में amnesia दिखता है. But important is in dementia, consciousness is absolutely intact. The patient is absolutely oriented to time, place, and person. Okay, here there is disorientation and clouding of consciousness. That's how you differentiate. And second important, dementia is acute in onset or gradual in onset? ग्रेजुअल इन ऑनसेट. अल्जाइमर्स एक दिन में होता है किसी को नहीं ना. डिमेंशिया में टाइम लगता है होने में, सालों साल महीने लग जाता है. बट delirium can occur in 1 or 2 days itself. ठीक है, it is very acute in onset. So these are the differentiating features between dementia and delirium. जैसे ही वो मेंशन करते हैं after 48 hours, after 72 hours, you have to think in terms of delirium tremens itself. ठीक है, you have to think in terms of delirium tremens because this timeline is very much important. Okay. So please remember 6 to 12 hours के बाद क्या होता है? Minor withdrawal symptoms like withdrawal tremors. Then 12 to 24 hours के बाद alcoholic hallucinosis. Then 24 to 48 hours के बाद withdrawal seizures. And lastly, after 48 to 72 hours, the patient will have delirium tremens. ठीक है? So answer should be delirium tremens over here. No issues with this, anybody? Please remember this. Corsac of psychosis में the patient has dementia. But there's again no clouding of consciousness, no disorientation. And in Corsac of psychosis, the patient will have the characteristic feature where the patient fills up memory gaps with false stories known as confabulation. This was a previous year question. Confabulation is a characteristic feature associated with which disorder? Answer was Korsakoff psychosis. ठीक है? Wernicke's encephalopathy is characterized by the classical case of Goa. It is again not acute in onset. ठीक है? And both of these are not in alcohol withdrawal. दोनों alcoholism में होते हैं, alcohol withdrawal में नहीं होते. ठीक है? And what is the drug of choice? कल ही बताया था मैंने, alcohol withdrawal के लिए drug of choice are benzodiazepines. Which benzodiazepine? Chlordiazepoxide, right? So chlordiazepoxide is considered as the best drug for alcohol withdrawal. This was a NEET-PG question. Chlordiazepoxide. Okay, important. Question number 157. A neonate had delayed cry after birth and developed features of hypoxic ischemic encephalopathy, that is HIE. On examination, he had hypotonia, that is decreased muscle tone. Okay, there is exaggerated ankle reflexes. There are recurrent focal seizures and there are myotic pupils. Myotic matlab constricted pupils hai bachche mein. What is the likely stage of HIE according to Sarnath and Sarnath staging system? How many stages are there? 3 stages are there according to Sarnath and Sarnath staging system for hypoxic ischemic encephalopathy. ठीक है? Stage 1 is known as mild encephalopathy, stage 2 is moderate encephalopathy and stage 3 is severe encephalopathy. Encephalopathy का मतलब होता है brain damage. क्यों हो रहा है brain damage बच्चे का? नाम में ये ना hypoxic ischemic encephalopathy. That means the child is having hypoxia. Increased oxygen. The child's brain is damaged, right? And क्यों हुआ hypoxia? Asphyxia. जब बच्चे का birth हो रहा था, the child was having suffocation. The child was asphyxiated. That is the reason why the child lands up into hypoxic ischemic encephalopathy. So birth asphyxia इसलिए important होता है to avoid, because otherwise the neonate will land up into HIE. And HIE will not only cause brain damage, that will also cause multiple other comorbidities in the child, ठीक है, which will be long lasting. So now HI की अगर मैं बात करूं, important कैसे, क्या क्या याद रखना है, not all the table, I am just highlighting क्या important है. Now important is level of consciousness. ठीक है, mild encephalopathy है, stage 1 में the child is hyper alert. ठीक है, the child is hyper alert. ठीक है, stage 2 में the child is lethargic. Okay, lethargic मतलब सुन्न पड़ा हुआ है, सुस्त पड़ा हुआ है बच्चा. ये obtunded, that means the child is confused. Okay, and child 3 में stage 3 में the child is stuporous. Stupor में है बच्चा or the child is in coma direct. ठीक है, so that's important. Then seizures, very important, और यही question बार बार आता है. ठीक है, seizures ये classical है. Seizures are not seen in stage 1. They may or may not be seen in stage 3, so not a characteristic feature. Seizures are commonly seen in stage 2 of HIE. Very important. Seizures are a common feature of stage 2 of HIE. This has been twice repeated question of your exam. Seizures are seen in which stage of HIE? Answer is directly stage 2 of HIE, that is moderate encephalopathy. ठीक है, important is next. Morrow's reflex, again a previous year question. Morrow's reflex is very strong in stage 1. It is weak or it is incomplete in stage 2, but it is completely absent in stage 3. What is the Morrow's reflex? It is also called as embrace equivalent. ठीक है, क्या होता है बच्चे में पहले? There is extension. Please remember, there is extension, abduction, okay, followed by flexion and adduction. This is what is called as Morrow's reflex or the embrace equivalent. Please remember. Next important is, you need to remember about the pupils as well. The pupils are dilated in stage 1. They are constricted or they are myotic in stage 2. Okay, and they are variable or there is very poor light response. They are not responding to light in stage 3. Not responding to light का मतलब क्या होता है? Non-reactive or very poorly reactive to light. ठीक है? Next important is heart rate. Tachycardia in stage 1, bradycardia in stage 2. Stage 3 में कुछ भी हो सकता है. Tachy, brady कुछ भी हो सकता है patient में. ठीक है? So that's important. Tone is important then. Tone में normal tone is seen in stage 1. Hypotonia या decreased muscle tone is seen in stage 2. And absent muscle tone मतलब ऐसा पड़ा है बच्चा, that is no muscle tone is there, that is flaccidity we call it. Muscle tone बिल्कुल नहीं है, उसको क्या बोलते हो? Flaccid. So flaccidity is seen in stage 3 usually. No issues with this anybody? तो इसी के हिसाब से posture भी होगी. Flexion कब होगा? Usually stage 1 में. Okay, strong distal flexion में कब होगा? Stage 2 में. That is called as decorticate position. And decerebrate या extension position में कब होगा? Stage 3. So important is to remember seizures. Important is to remember the tone of the muscle. Important is to remember Morrow's reflex and pupil. These 4 are the most important ones. ठीक है, जो highlight करे मैंने. So please tell me now, अपने बच्चे में, अपना बच्चा कौन सा stage में है? hypotonia, that is decreased muscle tone, exaggerated ankle reflex, focal seizures, myotic pupils. चार चीजों की वजह से पता चल गया the child is in stage 2. तो HIE stage 2 में है बच्चा. ठीक है. Oxygen supplementation should be given to the child because he is having HIE. If required, we can also intubate the child. ठीक है. Question number 158. A 2-year-old child presented with acute onset respiratory distress. ये दोनों सरकारी क्वेश्चन है. कभी कभी दोनों के दोनों आ जाते हैं एग्जाम में, कभी कभी एक तो आता ही है. हाँ, जरूरी नहीं है. बर्थ एस्फाइक्सिया इज द मोस्ट कॉमन कॉज. परफ्यूजन कम हो तो हो सकता है बिकॉज इस्कीमिया कॉजेस अल्टीमेटली हाइपोक्सिया ओनली, बट कॉमन कॉजेस एस्फाइक्सिया. इवन इफ देयर इज इनफ ब्लड सप्लाई एंड दैट डज नॉट कंटेन ऑक्सीजन, नो यूज ना. so that's important. बच्चे में परफ्यूजन की abnormalities कॉमन है, एस्फाइक्सिया कॉमन. एस्फाइक्सिया कॉमन है ना, बर्थ एस्फाइक्सिया. तो बर्थ एस्फाइक्सिया इज द कॉमन कॉज. 2-year-old child presented with acute onset respiratory distress with stridor. Stridor is noisy breathing, suggestive of upper airway obstruction, along with fever with chills, and there is drooling of saliva. Q, bacha is not able to swallow the saliva because swallowing is very, very painful. Q, the airway has been inflamed. Okay, there is a lot of inflammation and there's a lot of edema, okay, inside the throat. His X-ray is shown in the picture. What is the next step in management? Pehle, provisional diagnosis. Very good. A young child with respiratory distress, stridor, fever, chills, drooling of saliva. Very severe, very toxic child. X-ray, lateral, soft tissue neck, lateral view, showing with sign. So it is the inflamed epiglottis that you are able to see. That is nothing else but the thumb. Sign is usually seen. So diagnosis is definitely a case of acute epiglottitis. And acute epiglottitis is inflammation of the supraglottis, but the most common site affected is the epiglottis itself. Important, the most common cause, previous year question. Shabash. The most common cause is Streptococcus pneumoniae. I've told you the most common cause for acute epiglottitis is Streptococcus pneumoniae, followed by HIB, that is Haemophilus influenza type B. Please remember that. No issues with this. अगर वो unimmunized बोलता है, तब तुम HIB mark कर लो. But usually, otherwise, the most common cause is Streptococcus pneumoniae itself. This has been a previous year question. No issues with this, anybody? That's important. Now, if there is acute epiglottitis, there is inflammation of the supraglottis or the airway that causes laryngeal edema, due to which, as there is laryngeal edema, there is narrowing of the airway, that causes stridor, that causes difficulty in swallowing also, that causes drooling of saliva, that causes severe respiratory distress in the child. What is the immediate management? Very good. What did I tell you? Even if the child of acute epiglottitis is not having respiratory distress, the first step in management is early elective intubation or a prophylactic intubation. क्यों? क्योंकि already laryngeal edema है. अगर laryngeal edema और ज़्यादा हो जाता है, can you see the vocal cords? Can you go for intubation then? No. So it's better. बच्चे में पता है तुम्हें edema होने वाला है. So better is beforehand only intubate the child. Okay? Any laryngeal infections are a pediatric airway emergency. Yes, because children have lot of loose areolar tissue in the airway. बोला है ना ENT में ज़्यादा loose areolar tissue होता है, तो chances of laryngeal edema are much more as compared to the adult airway, and therefore chances of narrowing and spasm are much more in a pediatric airway. Therefore, laryngeal infections in children are always a pediatric emergency, airway emergency. ठीक है? So therefore, intubation should be done in the patient, followed by IV ceftriaxone. ठीक है? क्यों? It is a bacterial infection, and the drug of choice are third generation cephalosporins like ceftriaxone itself. ठीक है? इसके साथ साथ we will give nebulization also. Racemic epinephrine nebulization is given. मैं बोला ना bronchodilators के तौर पे क्या यूज करते हो? Epinephrine या adrenaline यूज करते हो. But usually that is given. But is that your next step or first priority in management? No. You will give it, but later. Then you also give what? Edema है. Edema कम करने के लिए steroids. Okay, so steroids are definitely given in this patient, but again they are not the first priority. ठीक है? IV ceftriaxone before any other modality. Infection बाद में ठीक करो, पहले बच्चे को सांस दो, नहीं तो बच्चा ही निकल लेगा. ठीक है? तो that's important. Urgent fiber optic laryngoscopy. Fiber optic laryngoscopy is never done. We only do a direct laryngoscopy because we have to intubate the child any which ways. तभी तुम examine कर लो. And repeated laryngoscopy, repeated checking of temperature, any other painful stimulus should be absolutely avoided. Reason is, अगर तुम बार बार बच्चे को दर्द दे रहे हो, बच्चा रोता जा रहा है. जब बच्चा रोएगा, स्पैज्म में चला जाएगा, लैरिंगोस्पैज्म, ओके, एंड दैट विल worsen the respiratory distress. That's the reason. ठीक है. Next, what is this? X-ray neck showing. It is known as the steeple sign. It is due to narrowing of the subglottis, and it is due to acute laryngotracheobronchitis, also known as TRAUP. What is the causative agent? Para-influenza virus. Previous year question again. Para-influenza virus. It is the infection of complete airway, laryngotracheobronchitis. But most common side affected is the subglottis, and therefore narrowing shows steeple sign on the X-ray. No issues with this, anybody? Important. यहाँ भी बच्चे में सब features होंगे like acute epiglottitis, but it will be less severe as compared to acute epiglottitis because it is not a bacterial infection, it is a viral infection. Second most important thing, here the child will have a very classic cough, and that cough is called as brassy cough or a barking cough. ठीक है? Brassy or a barking cough will be seen in the child. Important is the child will also have stridor, but that stridor will help you differentiate between epiglottitis and LTB. कैसे? Epiglottitis में the most common side affected is the supraglottis. Supraglottis obstruction causes, very good, inspiratory stridor. यहाँ पे inspiratory stridor होगा. And यहाँ पे the most common side affected, I told you, it is the subglottis. And subglottic obstruction causes, शाबाश, biphasic stridor. So that is how you differentiate it. ठीक है? क्यों पता है? Not always they will mention barking cough. Not always. करते हैं most of the times, but not always. ठीक है? तो इसीलिए तुम्हें बाकी differentiating feature पता होना जरूरी होता है इसमें. What is the treatment of choice in this patient? इसमें भी the first step in management will always be airway management. ठीक है? Intubation should be done in the patient if required. यहाँ पे if required, वहाँ पे always. ठीक है? Next important, we need to give epinephrine or adrenaline nebulization for bronchodilation. We need to give steroids to decrease the edema, and we also need to give antibiotics. The reason is the child is immunocompromised, so high risk of secondary bacterial infections. So to prevent that, we give antibiotics in acute laryngotracheobronchitis. ठीक है? So this was a previous year question. क्या क्या दिया जाता है? Please include antibiotics also in the regime of CRAUP. Question number 159. It states a 4-year-old child was brought with episodes of icterus and pallor. Icterus is nothing but yellowish discoloration. Along with that, there is pallor. ठीक है? So icterus is suggestive of jaundice in the patient. ठीक है? And there is pallor. Pallor is suggestive of anemia in the patient. ठीक है? The peripheral smear is given below. What is the likely diagnosis and investigation used for the same? What is seen on a peripheral blood smear, guys? What is this? So you are able to see RBCs. In RBCs में क्या दिख रहा है? सबसे ज्यादा जो सेल्स होते हैं जिनको दिक्कत आती है पेरिफेरल ब्लड स्मीयर देखने में, बेसिक है, जब सबसे ज्यादा जो लाल कलर के सेल्स दिखते हैं भाइयों, वो आरबीसीज होते हैं. क्या काउंट होता है आरबीसी का? 3.5 to 5.5 मिलियन. तो सबसे ज्यादा जो दिखेंगे वो आरबीसीज होते हैं. देन सबसे छोटे जो सेल्स दिखते हैं, दीज आर योर प्लेटलेट्स, क्योंकि सबसे स्मॉल साइज उन्हीं की होती है. देन डेफिनेटली जो बड़े बड़े सेल्स दिखते हैं, दोज आर योर डब्ल्यूबीसीज. अगर उसमें 3 से 5 लूप का न्यूक्लियस बना हुआ है, दैट इज व्हाट इज अ न्यूट्रोफिल, ओके, विद ग्रैन्यूल्स इनसाइड इट. अगर ऐसा कलर का ऐसा न्यूक्लियस बना हुआ है विथ नो ग्रैन्यूल्स, that is a monocyte. ठीक है? Kidney shaped nucleus with no granules inside it. Then definitely अगर ऐसा है, such a large nucleus, circular nucleus without any granules, it is a lymphocyte, T lymphocyte or a B lymphocyte. अगर ऐसा ही है, large nucleus with blue colored granules inside it, that is a basophil. Very good. And then if there is such a cell with a bilobe nucleus with pink color granules inside it, that is a eosinophil. That is how you differentiate. ठीक है? तो ऐसा देखना होता है. कम से कम पेरिफेरल ब्लड स्मीयर तो पता होना चाहिए यार. ऐसा नहीं होता. पैथो कैसे, हिमाट कैसे कर पाओगे उसके बिना? नॉर्मल तो देख लो. एक लिटरली दे जस्ट मार्क द नॉर्मल peripheral blood smear पे, they just mark one cell and they asked. Answer was basophil for that question. In one of the exam, the answer was lymphocyte for that question. People marked it wrong. ये पूछा था उन्होंने पेरिफेरल ब्लड स्मीयर में मार्क करके, सेल कौन सा है भाई? अगस्त एग्जाम में क्वेश्चन था. कैन यू बिलीव इट? तो मैं क्या बोल रहा हूँ, उनको ये नहीं चाहिए कि तुम कैंसर पिकअप करो यार. उनको ये चाहिए कि यार इनको नॉर्मल पेरिफेरल ब्लड स्मीयर तो पता हो. तो नॉर्मल तो याद रखना, देख लो. ठीक है? तो प्लीज रिमेंबर दैट इन द पीडीएफ, हेमाटोलॉजी पीडीएफ व्हिच इज देयर इंटीग्रेटेड सेशन का, उसमें पढ़ा हुआ है I've explained video अगर जिसको चाहिए depth में, it is present over there hematology. So please remember this. So these are the RBCs. Normal RBCs have what? Central pallor. But here the RBCs are lacking the central pallor. पूरी की पूरी लाल RBC दिख रही है. And yesterday I've told you, if the RBC is completely red, that is nothing else but a spirocyte. So spirocyte in an adult is suggestive of autoimmune hemolytic anemia. In a child, it is suggestive of hereditary spirocytosis. यहाँ कौन है? Child है. तो likely diagnosis क्या होना चाहिए? Hereditary spirocytosis. And what is the screening test? I'm saying screening. What is the screening test? It is osmotic fragility test, also called as Nestroff. What is Nestroff? Naked eye single tube RBC osmotic fragility test. ठीक है? So it is a osmotic fragility test itself. Please remember क्यों? क्योंकि अगर RBC नॉर्मली कौन सा शेप की होती है? बाय कॉनकेव शेप. तो अगर वो बाय कॉनकेव शेप की है, ठीक है, तो डेफिनेटली इट कैन मेक इट्स वे एंड इट कैन गो. But if it is spherical in shape, can it make its way from the capillaries? No. So it will be trapped in the capillary and it will be destroyed. ठीक है? So usually the RBCs, if they are spherical in shape, they will be trapped in the splenic capillaries and they will be killed. They will be destroyed over there. ठीक है? So that is what is done in osmotic fragility test also. Important, osmotic fragility test is also done in cases of thalassemia as well. It is also done for thalassemia, but it is a screening test always. What is the best investigation for hereditary spirocytosis? Very good. It is nothing else but protein analysis. क्यों? Hereditary spirocytosis. इसका shape क्यों spherical बन जाता है RBCs का? Because the RBC membrane protein which maintains the shape, they are defective itself. ठीक है? तो RBC membrane protein को देखोगे, वही तो best है फिर. So definitely the best test is nothing but RBC membrane protein analysis or electrophoresis. इलेक्ट्रोफोरेसिस पे ही देख सकते हो ना प्रोटीन्स. तो आरबीसी मेम्ब्रेन प्रोटीन इलेक्ट्रोफोरेसिस इज द बेस्ट इन्वेस्टिगेशन दैट कैन बी डन in cases of hereditary spherocytosis. Which is the most common protein defect? Ankyrin. Very good. In hereditary spherocytosis, it is not spectrin. It is ankyrin which is more common, followed by spectrin. ठीक है? In elliptocytosis, it is spectrin. In elliptocytosis, most common is spectrin, but in spherocytosis, most common is ankyrin. Most common is ankyrin. कोई दिक्कत नहीं है इसमें. Please remember that. ठीक है? No issues with this. तो याद रखना. And ये हेरिडिटरी स्पिरोसाइटोसिस का, चलो स्पिरोसाइट्स दिख गए, इससे डायरेक्ट डायग्नोसिस हो गया. इसीलिए पेरिफेरल ब्लड स्मीयर इतना इजी है. ठीक है? वो देखते ही डायग्नोसिस बन गया अपना. मुझे बाकी कुछ देखने की जरूरत नहीं पड़ी. हिस्ट्री भी लिटरली. ठीक है? तो यूजुअली क्या दिया हिस्ट्री में? जॉन्डिस है, अनीमिया है. I've told you yesterday, anemia which causes jaundice, anemia which causes bone marrow expansion like frontal bossing, anemia which causes hepatosplenomegaly. These are hemolytic anemia. राइट? तो हिमोलाइटिक अनीमिया की बात चल रही है. तो हिमोलाइटिक अनीमिया यहाँ पे तीन, यूजुअली ऑल ऑफ देम वर हिमोलाइटिक अनीमिया, बट इंपॉर्टेंट इज स्पिरोसाइट्स आर ओनली सीन इन टू ऑफ देम. वन वाज ऑटोइम्यून हेमोलाइटिक अनीमिया एंड सेकंड वाज हेरिडिटरी स्पिरोसाइटोसिस. ऑटोइम्यून हेमोलाइटिक अनीमिया इसलिए रूल्ड आउट बिकॉज इट इज यूजुअली सीन इन adult patients. Okay, so and direct Coombs test is the investigation of choice for autoimmune hemolytic anemia. Next, G6PD deficiency anemia. It is due to deficiency of an enzyme known as glucose 6 phosphate dehydrogenase enzyme. It is the rate limiting enzyme of which pathway? Very good. HMP shunt. ठीक है? Again, बायोकेम की इतनी भी बात मत लगाओ कि तुम रेट लिमिटिंग एंजाइम्स ना पता हो. ठीक है? Nobody is asking you pathways totally. At least rate limiting enzymes of important pathways. HMP shunt का rate limiting enzyme is G6PD. If that is deficient, definitely it is the most common enzyme deficiency in humans. Second most common enzyme deficiency in humans is pyruvate kinase. दोनों के दोनों में there is a hemolytic anemia which is seen. Please remember that. ठीक है? G6PD deficiency में usually this is the classical feature on peripheral blood smear. What are these cells? White cells, also called as helmet cells. ठीक है? White cells, helmet cells. And what are these bodies called as? Very good. The blue colored dots in RBCs, usually these are known as the Heinz bodies. So Heinz bodies, white cells, helmet cells, they are classical features of G6PD deficiency anemia in a patient. Please remember that. Okay? No issues with this, anybody? So remember that. G6PD deficiency anemia, usually the patient symptoms will worsen after eating what? That was the question. Drugs. Along with that, कौन सा खाना? Fava beans. Okay, fava beans is a worsening feature. जब तुम fava beans खाते हो, there is more and more hemolysis. The symptoms will worsen. Along with that, some drugs definitely good drugs. कौन से? Anti malarial drugs, जिनमें किनके नाम में क्वीन आता है. Okay, all the queen wala drugs, that is chloroquine, primaquine, mefloquine. ठीक है, all these drugs. Apart from that, nitrofurantoin, UT में देते हो ना, nitrofurantoin, sulfonamides. ठीक है, so these are the drugs usually which are known to predispose or which are known to worsen G6PD deficiency anemia. Okay, please remember that. No issues with this, anybody? So please remember this. Then if I talk about thalassemia, thalassemia ke liye usually the screening test which is there, it is what? Nestrop. Investigation of choices, HPLC, that is high performance liquid chromatography. But if they ask you best investigation or gold standard investigation, what is the problem in thalassemia? Hemoglobin जो होता है, hemoglobin is made up of two things, heme plus globin chains. Okay, heme मैंने बोला iron plus 4 protoporphyrin ring से बना होता है, और globin chains are in adult hemoglobin HbA. कितनी globin chain? 4, alpha 2, beta 2. So if these globin chains are absent, that is what is a thalassemia. क्यों? अगर globin chains are absent, the hemoglobin is normal or defective? डिफेक्टिव हीमोग्लोबिन है वो, और अगर डिफेक्टिव हीमोग्लोबिन है तो बॉडी will the body spare this type of RBCs? No, spleen will kill these type of RBCs. So thalassemia is which type of anemia? Hemolytic anemia. That's the reason why the child will have jaundice, the child will have hepatosplenomegaly. Rather, spleen is working overtime. क्यों? क्योंकि आरबीसीज को मारने का काम किसका होता है? स्प्लीन का. ठीक है, तो स्प्लीन इज अ ग्रेवयार्ड ऑफ आरबीसी. सेकेंड, अब आरबीसीज मारी जा रही है, तो आरबीसीज आर आल्सो बीइंग प्रोड्यूस्ड. व्हाई? बिकॉज आवर बॉडी ट्राइज टू कॉम्पेंसेट ना. So for compensation, our body tries to produce RBC. It will be produced in the bone marrow. Therefore, that causes bone marrow expansion. That leads to rental bossing, okay, prognathism. All of these features will be there. Sternal tenderness, all of that. But important is that will lead to chipmunk phases of thalassemia. But apart from that, this hematopoiesis or erythropoiesis, RBC formation, will also take place in the liver and spleen again. ठीक है, तो liver में there is erythropoiesis. Liver is working overtime. So there is hepatomegaly. Spleen is also forming RBCs. So there will be splenomegaly. Spleen is forming RBCs. Spleen is killing RBCs. ज़्यादा overtime कर रही है वो. So there should be more enlargement of spleen. So they will not write, in case of hemolytic anemias, they will not write hepatosplenomegaly. They will write splenohepatomegaly. That means the spleen is more enlarged because it is working overtime. मार भी रही है, बना भी रही है वो. ठीक है, so that's the basic idea. No issues with this, anybody? Splenohepatomegaly, jaundice, and frontal bossing or other features of bone marrow expansion are characteristic features of hemolytic anemia. ठीक है. Next important, and in thalassemia, peripheral blood smear shows what? These kind of cells. What are these cells known as? These are the classical target cells. Teardrop cells can also be seen, guys. But target cells are characteristic feature of thalassemia. Okay, pencil cells are seen in iron deficiency anemia. Very good. ठीक है, best investigation. This was the previous year question. बताओ, best investigation for thalassemia. क्या क्या? Best investigation. PCR, ग्लोबिन जीन एनालिसिस. क्या बेस्ट होगा कि जीन ही देख रहे हो, जीन ही डिलीटेड है तो चेन्स ही नहीं बन रही, चेन्स नहीं बन रही, इसीलिए थैलेसीमिया हो रहा है ना. What can be best than this if you are able to see the genes directly? So this was a previous year question. One of the options was HPLC and another option was globin gene analysis. Answer should be globin gene analysis is the gold standard of the best investigation to confirm a case of thalassemia. क्योंकि अगर जीन ही देख रहे हो तो उसके बाद कुछ बचता ही नहीं है डाउट. ठीक, HPLC में भी डाउट हो सकता है, बट ग्लोबिन जीन एनालिसिस के बाद कोई डाउट नहीं है. इट विल आल्सो कंफर्म इट इज अ केस ऑफ अल्फा थैलेसीमिया और थैलेसीमिया. मोर कॉमन इज बीटा थैलेसीमिया. ठीक है, एंड द ट्रीटमेंट इज यूजुअली इन केसेस ऑफ मेजर बीटा थैलेसीमिया और मेजर अल्फा थैलेसीमिया, recurrent blood transfusions in the patient. ठीक है. Question number 160. A 10-year-old boy presented with complaints of recurrent epistaxis. Okay, and there is pain and swelling in both the knees. Epistaxis is nothing but nose bleeds, and there is pain and swelling in both the knees. X-ray knee has been given below, and coagulogram reveals normal BT, PT, but a prolonged APTT. What is the likely cause? कुछ भी करने से पहले मुझे coagulogram एक तीन चीजें बता दो. PT, that is bleeding time, tells you about any defect or deficiency of platelet. शाबाश. जिसको ये नहीं पता, वो केस में कुछ नहीं कर पाएगा। लेट मी टेल यू, कोएगुलोग्राम इंपॉर्टेंट है, ये होता है मेडिसिन में, अगर ये नहीं पता तुम आगे पता ही नहीं कर पाओगे, क्योंकि बहुत सारी कंडीशंस में ओवरलैप होता है। तो पीटी इज व्हाट, प्रोथ्रोम्बिन टाइम, प्रोथ्रोम्बिन टाइम also called as INR, International Normalized Ratio. So PT or INR will tell you about any defect or deficiency of which pathway of coagulation? Extrinsic pathway of coagulation. Extrinsic pathway में बस एक clotting factor होता है, clotting factor number 7. Next, APTT, activated partial thromboplastin time. It will tell you about any defect or deficiency in which pathway of coagulation? Intrinsic pathway of coagulation. ठीक है? Here we have clotting factors like 11, 9, 12, 8. ठीक है, तो एटलीस्ट इतने याद रख लो। तो इनमें कोई भी डिफेक्ट होता है, then definitely there will be problem in the intrinsic pathway and which time will be prolonged? APTT will be prolonged. ठीक है, तो याद रखना। अगर प्लेटलेट्स कम है, that is thrombocytopenia, which time is prolonged? PT is prolonged. If there is some defect in the platelets like Bernard-Sollier syndrome, Wiskott-Aldrich syndrome, or it can be Glanzmann thrombasthenia. Okay, in this condition again, which time will be prolonged? Bleeding time will be prolonged. Then definitely, if they say there is deficiency of clotting factor number 7, which time will be prolonged? PT or INR will be prolonged. Anybody? कब होता है PT prolonged? Very good. Warfarin toxicity, because warfarin inhibits clotting factor 2, 7, 9 and 10. That's the reason important. Please remember, in warfarin toxicity there is problem in clotting factor number 7, therefore the time which is prolonged is the PT INR. Please remember that. No issues with this, anybody? And APTT will be prolonged in which condition? 8, 9, 11, hemophilia usually. Okay, so please remember that. तो चलो, नाउ 10-year-old बॉय कंप्लेन्स ऑफ रिकरेंट एपिस्टैक्सिस, मतलब बार बार ब्लीडिंग हो रही है। अर्लीस्ट फीचर क्या होता है? एक्सेसिव ब्लीडिंग ड्यूरिंग सर्कमसिजन. दैट इज द फर्स्ट फाइंडिंग ऑफ द फर्स्ट टाइम व्हेन वी गेट टू नो कि द चाइल्ड इज हैविंग अ लॉट ऑफ ब्लीडिंग एपिसोड्स. नेक्स्ट इज पेन एंड स्वेलिंग इन बोथ द नीज. एक्सरे पे क्या दिख रहा है? हेजीनेस दिख रहा है तुम्हें? देयर इज अ लॉट ऑफ हेजीनेस इन द नी. हेजीनेस इज नथिंग बट ड्यू टू कलेक्शन ऑफ ब्लड इनसाइड द नीज. दैट इज सजेस्टिव ऑफ, very good, it is suggestive of hemarthrosis, that is collection of blood or bleeding inside the knee joint. The child will have bilateral hemarthrosis in this condition. Okay? And coagulogram reveals what? There is a normal PT. So is there any defect in platelet? No. Normal PT. So any defect in the extrinsic pathway? No. What is prolonged? APTT is prolonged. मतलब कौन से factors? 8, 9, 11. Clotting factor 8 deficiency is known as hemophilia type A. Clotting factor 9 deficiency is known as hemophilia type B. And clotting factor 11 deficiency is known as hemophilia type C usually. ठीक है? Hemophilia type A and B are X-linked recessive. That means they will be only seen in boys, males, whereas it will be females will just be carriers for the disease. Okay. Hemophilia B is also known as royal disease या Christmas disease, क्योंकि प्रिंस चार्ल्स को था. ठीक है? Please remember. No issues with this, anybody? Now, so what is the condition over here? So definitely it is deficiency of clotting factor 8 or 9. That means it is a case of hemophilia in the patient. Please remember that. No issues with this, anybody? Now, can anybody tell me which is the most common hereditary bleeding disorder? मतलब जो families में run होती है. Most common hereditary bleeding disorder. The most common hereditary bleeding disorder is von Willebrand's disease. Okay, the most common hereditary bleeding disorder is von Willebrand disease. Von Willebrand disease means deficiency of there is deficiency of von Willebrand factor. I hope all of you are quite aware. ये जो von Willebrand factor होता है, it is present beneath the endothelium. So whenever there is injury to the endothelium, this von Willebrand factor is exposed, and therefore all the platelets will be attracted towards it. These platelets will come, they will attach to the von Willebrand factor and form the primary clot. Then the clotting cascade will be activated, and then finally at the end there will be a mesh which is formed of fibrin over this clot, making it more stronger. That is a secondary hemostatic clot which is formed. Okay? So that's the basic idea. And then after calm ho jata hai, so this clot is broken down by the fibrinolytic system, protein C, protein S, and antithrombin 3 usually. Okay? अरे coagulation रे, याद रखना, पूछ लेते इंटर्नशिप में, कम से कम इंटर्नशिप शुरू हो तो पढ़ लेना. ठीक है? So important is that. No issues with this anybody? तो von Willebrand factor अगर काम नहीं कर रहा होगा, if it is deficient or if it is not working, definitely can a clot form? No. Due to that reason, the patient keeps on bleeding a lot. Okay, so that is what is seen in von Willebrand disease. Important is that. Please remember. Now, in cases of von Willebrand disease, can anybody tell me which time will be prolonged out of these three? BT will be prolonged. Why BT will be prolonged? Because platelet aggregation will not happen. So platelet aggregate nahi kar pa rahi, that means therefore the bleeding time will be prolonged. Apart from that, bleeding time तो platelet thrombocytopenia में भी prolonged होगा. Bleeding time तो Granzman thrombocytopenia, Bernard-Sollier syndrome, Wiskott-Aldrich syndrome तीनों में prolonged होगा. Very good. APTT. Why APTT? Anybody? Shabash. Because this von Willebrand factor is responsible for activation of factor 8. It is responsible for clotting factor activation of clotting factor 8. अगर von Willebrand factor नहीं है, clotting factor 8 activate होगा क्या? नहीं होगा. और जब clotting factor 8 नहीं होता तो कौन से pathway में दिक्कत आती है? Intrinsic pathway. और कौन सा time prolong होता है? APTT. समझे अभी? ये बस दिखा सकता है जब BT और APTT prolong हो, direct diagnosis is von Willebrand disease. Direct diagnosis is von Willebrand disease. ठीक है, इसीलिए ये कीवर्ड्स उठाते जाओ. ये दोनों प्रोलॉन्ग्ड है, मतलब डायरेक्ट डायग्नोसिस मेरा, मुझे और कुछ देखना ही नहीं है. आई टेल यू, मैं अश्योर करता हूं, डायरेक्ट डायग्नोसिस कैन बी von Willebrand disease. ठीक है, दैट्स इंपॉर्टेंट. नेक्स्ट इंपॉर्टेंट इज दिस, वेरी क्लासिकल एंड सरकारी क्वेश्चन ऑफ योर एग्जाम. बार बार इमेज क्वेश्चन में आता है. इसमें याद रखना, इम्यून थ्रोम्बोसाइटोपेनिक पर्प्यूरा क्यों नहीं हो सकता, von Willebrand disease क्यों नहीं हो सकता, मैंने बताया. बिकॉज हिज EPTT is prolonged, but the bleeding time is normal. So that's the reason his von Willebrand disease cannot be a cause. Immune thrombocytopenic purpura क्यों नहीं हो सकता? Again, thrombocytopenic, that means there is deficiency of platelets, due to which there will be prolonged bleeding time. Is bleeding time prolonged over here? No, it is normal. So that can be ruled out. Defect in glycoprotein 2B3A receptor. Defect in glycoprotein 2B3A receptor. Anybody? Bernard-Sollier syndrome. The platelets are not able to attach with the von Willebrand factor, and that's the reason why. Again, platelet aggregation नहीं होता, platelet में defect है, तो कौन सा time prolong चाहिए? BT. क्या है यहाँ पे? BT is absolutely normal. That's the reason why I can rule it out as well. Next, if I talk about, इसीलिए मैं बोलता हूँ BT, PT और APTT से ही सब diagnosis बनते हैं bleeding disorders के. So please make that sure you write it in front of you and stick it कि कौन सा factor में कौन सा time prolong होता है. ITP is very important. Immune thrombocytopenic purpura. Acute and chronic ITP. Children में कौन सा होता है? Acute ITP. Adults में कौन सा होता है? Chronic ITP. Now, important is antecedent history of infection. Antecedent infection मतलब history of infection. कौन से condition में they will give a history of viral or bacterial infection? In acute ITP. In acute ITP, they will give a history of viral or bacterial infection. That history will not be present in a case of chronic ITP. Please remember. Onset of bleeding. Bleeding अचानक से शुरू किस में होती है? Acute ITP. It will be very gradual. It will take a longer time in chronic ITP. नाम में ही पता चल रहा है ना, chronic है वो. ठीक है, please remember. Next important condition that you need to remember over here. Duration. Acute ITP usually takes 2 to 6 weeks. Okay, whereas chronic ITP takes months or years. कैसे प्रेजेंट करेगा पेशेंट? डेफिनेटली इफ देयर इज इम्यून थ्रोम्बोसाइटोपेनिक पर्प्यूरा, थ्रोम्बोसाइटोपिनिया है मतलब डिक्रीज प्लेटलेट काउंट, पेशेंट में ज्यादा क्या होगी? ब्लीडिंग. देयर विल बी मोर ब्लीडिंग, एपिस्टैक्सिस वगैरह. अपार्ट फ्रॉम दैट, क्लासिकल नाम में ही है ना, पर्प्यूरा, ब्लीडिंग स्पॉट्स विल बी सीन, पेटिके पर्प्यूरा एक्केमोसिस विल बी सीन. ठीक है. नाउ इंपॉर्टेंट इज, if they say there is a child, this was an August 2020 question, if they say there is a child who is coming to you with multiple bleeding episodes with purpura, image was given, and they say the mother gives history of some viral or bacterial infection 2 to 3 weeks ago, what is the diagnosis? And the question which was asked, what is the treatment? Spontaneous remission, that means resolution, self-limiting condition in 80% of the cases. अपने आप ठीक हो जाता है बच्चा. Therefore, no treatment या reassurance was the answer. Reassurance or no treatment should be the answer for acute ITP. Whereas chronic ITP में spontaneous remission होता है क्या? नहीं होता. Therefore, the drug of choice are immune ना, मतलब autoimmune condition है. Therefore, we need to give steroids. So please remember, acute ITP, the treatment is no treatment or reassurance. Chronic ITP, the drug of choice are steroids. Children में acute, adults में chronic. History of infection, acute. No history of infection, chronic. Please remember. ठीक है. So that will help you make a diagnosis of ITP very easily. ठीक है? If they say guys that the platelet levels are normal, then also there are bleeding episodes. Then also there are purpura on the lower limbs and buttock. There is arthralgia and there is abdominal pain. Very good. सरकारी क्वेश्चन ऑफ योर एग्जाम HSP हेनॉक शॉनलेन पर्प्यूरा. बच्चे में प्लेटलेट लेवल्स नॉर्मल है, ये कीवर्ड होता है. प्लेटलेट लेवल्स नॉर्मल है, बट देयर इज पर्प्यूरा ऑन द लोअर लिम्ब एंड बटॉक्स, वेरी कैरेक्टरिस्टिक, along with the other features like abdominal pain and arthralgia, that is joint pain. ठीक है, आगे बढ़ते. क्वेश्चन नंबर 161. It states what? It states a child was brought to your OPD with complaints of difficulty in walking and there is delayed dentition. मतलब दांत नहीं आ रहे जल्दी बच्चे के, delayed dentition. On examination there is wrist widening. जो तुम wrist देखते हो ना, the wrist is widened over here. ठीक है, is present and lab workup reveals the serum calcium levels are normal, serum phosphate is low, serum parathormone is high, serum ALP alkaline phosphatase is high. ठीक है, what is the likely diagnosis in this child? So it is a case of rickets. Important is, rickets is what? Rickets is due to deficiency of vitamin D. Vitamin D is responsible for mineralization of bone. What is mineralization? Deposition of calcium and phosphate inside the bone. तो अगर vitamin D कम होगा तो mineralization हो पाएगा क्या? नहीं हो पाता. Therefore the bones will become weak. Okay, the bones will become weak. They will be demineralized. ठीक है, so that's the important thing which is seen. Now in cases of rickets, definitely mineralization is not only required in bone, it is also required for teeth. Therefore there is delayed dentition in a case of rickets. Apart from that, definitely as the bones are weak, the child will have a lot of difficulty while walking. Apart from that, characteristic feature of rickets बता रहा हूँ. Wrist देखनी होती है बच्चे की. Wrist X-ray में usually there is widening of wrist, and the widening of wrist is due to these three features. क्या दिख रहा है? First of all, the metaphysis is widened. This metaphyseal widening is known as splaying. Metaphyseal widening is known as splaying. Then you can see there is a cupping at the metaphysis. So there is cupping usually which is seen. And third, if I say the border दिख रही है, sharp है या irregular है? Irregular है ना? So this is called as fraying. So splaying, cupping and fraying of metaphysis is the characteristic feature of rickets. Characteristic feature of rickets. ठीक है? Splaying, cupping and fraying of metaphysis is characteristic feature of rickets. X-ray wrist will be the best X-ray to be taken in a diagnosis of rickets usually. कोई दिक्कत नहीं है इसमें. So that's the important thing you need to remember. ठीक है? And now, so some people will say, sir, vitamin D is known to increase serum calcium levels. So if vitamin D is deficient, the patient should have what? Decreased serum calcium. Important is बच्चों, क्या दिख रहा है यहाँ पे? Now, when there is decreased serum calcium, इस बच्चे में होगा decreased serum calcium, but उसकी वजह से whenever there is decreased serum calcium, that is hypocalcemia, immediately a signal will be going to parathyroid gland, and a lot of parathormone will be secreted. So can you see the parathormone levels are high? Yes. Now when parathormone is secreted, it will cause two things. First of all, it will cause activation of vitamin D synthesis. It will cause activation of, because it stimulates the rate limiting enzyme of vitamin D synthesis known as 1-alpha hydroxylase in the kidney. Please remember. Okay, so that causes vitamin D synthesis. तो चलो इन केस यहाँ विटामिन डी एंडोजेनसली तो सिंथेसाइज होगा ना, डाइट में डेफिशिएंसी है, चलो वो भी नहीं हो रहा बच्चे में. सेकंड एक्शन ऑफ पैराथॉर्मोन इज व्हाट? इट एक्टिवेट्स osteoblast at lower doses. Again, parathormone at lower doses activates osteoblast, and then osteoblast will further activate osteoclast. ठीक है, तो इसीलिए बोला जाता है in a case of osteoporosis, we can give low doses of parathormone. We can give low doses of parathormone. क्यों? क्योंकि low doses of parathormone will only activate osteoblast. It will not activate osteoclast. And that low dose parathormone given in osteoporosis is known as injection of teriparatide. अब समझे इसका लॉजिक कि पैराथॉर्मोन क्यों दे रहे हो यार? ये तो आया होगा ना सवाल मन में, तो ये पूछना होता है. फिर अगर सवाल आता है तो पूछना होता है कि क्यों नहीं देते भाई, क्यों दिया जाता है? तुम तो बोल रहे हो बोन रिजॉर्प्शन कर रहा है, दूसरी तरफ तुम ऑस्टियोपोरोसिस में दे रहे हो उसको. पूछो तो सही टीचर्स को, परेशान करके छोड़ो. Nobody is going to complain. Literally, let me tell you that. Important is that. So please remember, finally osteoclast will be activated, and osteoclast will cause what? Active clast will cause bone resorption, that is breaking down of bone. Okay, पहली bone उसकी weak है, उसमें भी वो और break down कर रहा है bone को, bone resorption कर रहा है, and that is how it is taking calcium away from the bone into the blood to increase or to normalize the serum calcium levels. तो यहाँ पे पैराथॉर्मोन हाई है, इसीलिए क्या हो गया, सीरम कैल्शियम की लेवल्स अभी भी नॉर्मल आ रही है, बिकॉज it has activated the osteoclast, and therefore there is bone resorption which is going on. Therefore the calcium from the bone is being brought to the blood, and that is the reason why the serum calcium levels in this child are normal. ठीक है, तो हो सकते हैं नॉर्मल, ये मुझे बताना था in the case of rickets when the parathormone levels will be high. And जब parathormone levels high होती है, it will activate osteoblast, and whenever the osteoblast will be activated, enzyme will be very high, that is alkaline phosphatase, also known as SAP, serum alkaline phosphatase. Levels of SAP are high whenever osteoblasts are activated. तो जब भी osteoblastic activity चलती है, SAP levels will be high. Osteoblastic activity किस में चलती है? Later stages of Paget's disease also. Therefore, in Paget's disease, SAP is very, very high. Okay, so that's the basic idea. No issues with this, anybody? Can anybody tell me in osteoporosis, what happens to serum calcium, serum phosphate, and serum, vitamin D levels? Serum calcium, serum phosphate, and vitamin D levels in osteoporosis. Osteoporosis में क्या होता है? दिक्कत आ रही है ना? क्या हो रहा है? बोन्स वीक है तुम्हारे, क्या हो जाना चाहिए? Everything will be absolutely normal. ठीक है, तो प्लीज रिमेंबर दिस, सीरम कैल्शियम, सीरम फॉस्फेट एंड विटामिन डी लेवल्स आर एब्सोल्युटली नॉर्मल इन केस ऑफ ऑस्टियोपोरोसिस. प्रीवियस ईयर क्वेश्चन है, वो इसीलिए पूछते हैं बिकॉज ऑल ऑफ अस नो कि ऑस्टियोपोरोसिस इज वीकनेस ऑफ बोन. तो हम सब क्या मार्क करेंगे? डेफिशिएंसी नहीं होती. ओके, देयर इज, प्लीज रिमेंबर, मिनरलाइजेशन में दिक्कत नहीं आती. डेफिनेटली आफ्टर डिपोजिशन द बोन्स व्हिच आर देयर ना, दे आर एब्सोल्युटली वीक. देयर इज, जो बोन होता है ना, उसमें पोर्स बन जाते हैं. ऑस्टियोपोरोसिस क्या होता है? देयर आर पोर्स इन द बोन्स, देयरफॉर द बोन्स विल बिकम वीक, दे विल बिकम फ्रेजाइल, एंड दे विल बिकम इजीली ब्रेकेबल. ठीक है, तो दैट्स द बेसिक आइडिया इन ऑस्टियोपोरोसिस. नो इश्यूज विद दिस एनीबॉडी? तो ये बहुत इंपॉर्टेंट क्वेश्चन है, प्लीज रिमेंबर दैट. ठीक है, इंपॉर्टेंट इज रिकेट्स में एक्सरे शोज मेटाफाइजियल कपिंग, प्रेइंग स्प्रिंग. अगेन स्नैप्स का ही इमेज है, तो कम से कम वो पढ़ा होता तो क्वेश्चन सॉल्व हो जाता. नेक्स्ट इंपॉर्टेंट इज पेनलेस बीडिंग ऑफ कोस्टोकॉन्ड्रल जंक्शंस. ओके, दैट इज नॉट नथिंग बट रैकेटिक रोजरी. ठीक है, I hope all of you are quite aware. In cases of rickets, what is the abnormality that is seen in the knees? ये नहीं, normally most common. Geno varus या valgum? Varus, that is bowing of legs. Okay, so in cases of rickets, the child will present commonly with geno varus, that is bowing of legs usually. But sometimes there can be one leg showing geno varus, the other leg showing geno valgus, and that is what is called as wind-swept deformity. Most common cause of wind-swept deformity in child is nothing else but rickets. Most common cause of wind-swept deformity in adults is rheumatoid arthritis. Please remember that. No issues with this. Most common cause of geno valgus in adults, rheumatoid arthritis. Most common cause of geno varus in adults, osteoarthritis. भाई ऐसे याद रखना ना, geno varus O बन रहा है बीच में, geno valgus R बन रहा है. That is how you remember it. ठीक है, तो geno varus is associated with rheumatoid. Geno varus is associated with osteoarthritis. Geno valgus is associated with rheumatoid arthritis. No issues with this, anybody? That's how you remember it. Okay, and this is what Harrison's sulcus or the Harrison's groove, which is seen in cases of rickets. Again, please remember, this is the case of Paget's disease. Paget's disease में कम से कम X-ray findings पता होनी चाहिए. What is this, anybody? Can you see the margins or the borders of the vertebra are very, very white in color? That is nothing else but the picture frame vertebra. That is picture frame vertebra. If one of the vertebra is completely white, that is called as, very good, that is what is known as the ivory vertebra. That is what is called as ivory vertebra, also a feature of Paget's disease. Then important, next one. In cases of this one, X-ray skull shows what? Cotton wool skull classically. And this is what? Again, the margins or the cortex of the bone are very, very thick and white. These are called as bone within bone appearance. It is known as bone within bone appearance. Please remember. No issues with this. And important is in the skull also, in the early stages. मैंने क्या बोला? Paget disease दो stages में होता है. Early stages में there is bone breaking, that is osteolysis. Later stages में there is bone forming, that is osteogenesis. Please remember. So early stages में when there is bone breaking or there is osteolysis, what happens in the skull? कुछ पार्ट में तुम्हें ऑस्टियोलाइटिक लीजन दिखेगा, दैट इज नोन एज ऑस्टियोपोरोसिस सर्कमस्क्रिप्टा. ऑस्टियोपोरोसिस सर्कमस्क्रिप्टा इज सीन विद पेजेट्स डिसीज. रेनड्रॉप skull, मल्टीपल माइलोमा. ओके, पेपर पॉट स्कल, हाइपर पैराथायरॉयडिज्म, पेपर पॉट स्कल. ओके, और सॉल्ट एंड पेपर स्कल एक ही चीज होती है वो. नेक्स्ट इंपॉर्टेंट, जोग्राफिक स्कल, eosinophilic granuloma, which is a subtype of Langerhans cell histiocytosis. Please remember this. ठीक है? And crew cut appearance or hair on end appearance, thalassemia or any other type of hemolytic anemia. ठीक है? So that's the important thing. ये at least X-ray याद रखते हैं. Now, and rickets में क्या देते हो तुम? Calcium देते हो and vitamin D supplementations देते हो बच्चे में. ठीक है? So those are to be given in a case of rickets. Question number 162. 3-year-old male biker was brought to the emergency room, okay, after a road traffic accident with case of polytrauma. On examination, multiple fractures were suspected. So it is a case of polytrauma in which ways, and basic resuscitation was done, and he was admitted in the ICU. On the next day, patient's SpO2, okay, started dropping. Saturation of oxygen started dropping, and there were petechiae which were noticed in his axilla. What is the diagnosis? पल्मोनरी एम्बोलिज्म वाले हार्ट उठाना जरा. पेटेकिया कब से होने लगे पल्मोनरी एम्बोलिज्म में, ये बताओ जरा मुझे. व्हाट इज द क्राइटेरिया? क्राइटेरिया डायग्नोसिस का सरकारी क्वेश्चन है, इसलिए इतना मैं बोल रहा हूँ. मेडिसिन प्लस ऑर्थोपेडिक्स दोनों से क्वेश्चन आता है. वेरी गुड, गर्ड. सो इट इज द गर्ड क्राइटेरिया. क्या निमोनिक दिया था गर्ड क्राइटेरिया का? अरे क्या क्या होता है रे भाई? आरसीपी, पीसीआर, जो भी बोल लो तुम उसको. पीसीआर बोल लो, आरसीपी बोल लो. ठीक है? आर से रेस्पिरेटरी सिम्टम्स. ठीक है? So the patient will have breathlessness, shortness of breath, respiratory distress, SpO2 falling, anything like that, dyspnea, tachypnea, anything like that. Respiratory symptoms. C goes for CNS symptoms, that is altered sensorium, confusion, drowsiness, lethargy, anything like that. And P goes for petechiae. Major criteria ना ये fat embolism का. Petechiae, characteristic site of petechiae, axilla, but it can be seen anywhere usually. Okay, so please remember that is RCP, PCR. Major criteria for fat embolism syndrome. Minor criteria बहुत सारा हो सकता है. There will be elevated ESR, elevated CRP, increased temperature, that is fever in the patient. Along with that, fat globules in the sputum or urine of this patient. Definitely, all of these are minor criteria. But major criteria तो याद होना ही चाहिए. These are the three major criteria for fat embolism syndrome, which are known as the GERD criteria. Please remember that. ठीक है? So definitely, as they are saying, it is a case of polytrauma. Fat embolism ये थोड़ी होगा. ये बताओ मुझे जरा कि only the patient is having a shaft of femur fracture and now he is complaining of respiratory distress. तो मैं क्या बोल रहा हूँ? Only, not only after a long bone fracture, but after a case of polytrauma also the case can have fat embolism syndrome ना. क्योंकि in polytrauma also there are multiple fractures, there can be long bone fractures also, and when there are long bone fractures क्या होता है? The bone marrow में क्या होता है? Bone marrow में fat होता है ना. So that bone marrow fat will come outside, and that fat will be broken down to fatty acid. These free fatty acids which will be there, they are known to cause toxic vasculitis of which vessels? Of the pulmonary vessels causing respiratory symptom, CNS or brain vessels causing CNS symptoms, and skin vessels causing petechiae. ठीक है? So toxic vasculitis, inflammation of the vessels in the respiratory system, CNS, and on the skin, that causes these three major criteria. ठीक है? So that is what is seen in fat embolism syndrome. Please remember that. No issues with this, anybody? So that is important. So here the diagnosis should be option C, fat embolism syndrome. What is given to the patient? After basic resuscitation, definitely what we need to give? डेफिनेटली ऑक्सीजन सप्लीमेंटेशन वगैरह हैज टू बी स्टार्टेड इन द पेशेंट, रिक्वायर्ड इंट्यूबेशन कर दो पेशेंट का, और आईपीपीवी और low molecular weight heparin is also started in this patient because it is embolism ना. तो embolism के cases में क्या करते हो, emergency anticoagulant देते हो, and emergency anticoagulant of choice is nothing but low molecular weight heparin itself. That is also done in cases of massive pulmonary embolism. Massive pulmonary embolism में कैसी issue होगी बताओ जरा. Trauma के बाद आता है क्या patient pulmonary embolism का? DVT, very good. There should be a history of DVT in a patient, deep venous thrombosis, or a history of nephrotic syndrome in a patient. क्यों? दोनों कंडीशंस में, और इवन अ केस ऑफ हिस्ट्री ऑफ प्रेगनेंसी इन अ पेशेंट. क्यों? ऑल ऑफ दीज क्वेश्चन, वेरी गुड, ऑल ऑफ दीज केसेस आर सजेस्टिव ऑफ हाइपर coagulability, or all of these stages are suggestive of hyper coagulable state. What do I mean by hyper coagulable state? That means the blood is more thick or less thick. The blood is more thick. As blood is more thick, chances of clot formation are more. So chances of thrombus formation will increase. Virtuous triad: endothelial injury, hypercoagulability, and stasis of blood flow. ठीक है? So इसीलिए thrombus बनता है. So definitely any hypercoagulable state like DVT, prolonged immobilization, pregnancy, nephrotic syndrome. Okay. So all of these conditions are known to cause hypercoagulability. Due to that, there is increased risk of thrombus formation. And उसके बाद अगर prolonged immobilization होता है, like prolonged immobilization के लिए क्या बोलेंगे वो? Either the patient has underwent a major surgery जैसे total hip replacement, total knee replacement, or they will say that the patient is having cervical spine fracture, or the patient is having some orthopedic fracture. For that reason, he cannot walk and he is given a bed rest. So that is talking about prolonged immobilization. और prolonged immobilization में और हो सकता है क्या? Long flight. तो ठीक है, तो pulmonary embolism ये बहुत क्लियर कर देता हूँ आज दिमाग में. कैसा आएगा क्वेश्चन? फर्स्ट, there should be some risk factor. Risk factor क्या होता है यूजुअली? Hyper coagulable state, DVT, pregnancy, nephrotic syndrome, or any condition like this. ठीक है, please remember. Next, cause देंगे वो. What is the cause? Prolonged immobilization. That is, they will say bedridden patient or a chronic bed rest due to major surgery like a TKR or a THR, or an orthopedic or a cervical spine fracture in the patient. ठीक है, और a long flight from New York to Delhi, for example. ठीक है, and उसके बाद they say as the patient starts walking, the patient experiences respiratory distress. Patient बैठे बैठे हो तो respiratory distress नहीं होता है. ठीक है, what happens when the muscles will contract? As the muscles contract, the thrombus gets dislodged, and the thrombus will go into the pulmonary vessel and will cause pulmonary embolism in the patient. The patient will suffer from respiratory distress, dyspnea, breathlessness, saturation falls, but no petechiae, no CNS symptoms are seen in cases of pulmonary embolism. It is purely respiratory symptom, purely respiratory in pulmonary embolism. That's important. ठीक है, and submassive and massive pulmonary embolism होता है. Submassive में the patient will only have respiratory distress or breathlessness, बाकी कुछ नहीं होगा. But in massive pulmonary embolism, the patient collapses. The patient has to be taken to the emergency or the patient will die. ठीक है, ये हिस्ट्री दी जाती है मैसिव में. सब मैसिव अगर होगा, नो ईसीजी चेंजेस, नो एक्सरे चेंजेस. मैसिव होगा तो ईसीजी चेंजेस आर सीन, दैट इज S1 Q3 T3 पैटर्न, एंड एक्सरे चेंजेस आर सीन. तीन साइन: हैम्पटन हम्प साइन, पल्ला साइन, एंड वेस्टरमार्क साइन. ठीक है, so these changes are seen in massive pulmonary embolism. Submassive pulmonary embolism है, what is the treatment? Anticoagulation, only low molecular weight heparin along with warfarin. But massive pulmonary embolism hai, then we need to go for catheter directed thrombolysis. Okay, thrombolysis is done with drugs like retiplase, altiplase, and tenecteplase. ठीक है, streptokinase is avoided nowadays due to allergy. कोई दिक्कत नहीं है अभी, समझ गए? हाँ, फैट एम्बोलिज्म सिंड्रोम है यूजुअली. फैट एम्बोलिज्म सिंड्रोम में डेफिनेटली व्हाट इज द क्लासिकल साइन व्हिच इज सीन दिस? क्या अपीयरेंस दिख रहा है एक्सरे पे? Can you see complete ground glass appearance, or you can see patchy infiltrates? Patchy infiltrates, and this patchy infiltrates give a classical appearance, and that is what is very good, snowstorm appearance. So snowstorm appearance is usually seen on the chest X-ray. याद रखना, snowstorm appearance is a classical feature of fat embolism syndrome, which is suggestive of patchy infiltrates in both the lungs. अगर तुम्हें पूरा का पूरा ground glass appearance दिखता है, that is ARDS, that is acute respiratory distress syndrome, or in a neonate registry of RDS, that is respiratory distress syndrome or hyaline membrane disease. और it was also seen in cases of COVID-19 pneumonia, क्योंकि patient मरता ही किस ARDS से. Finally, it is ARDS or RDS that you need to remember. Ground glass appearance. No issues with this, anybody? So please remember that. Okay. So this usually multiple organ failure, definitely here there is not a case of multiple organ failure, because multiple organ failure में the first organ usually which is affected is the kidneys. Oliguria होता patient में सबसे पहले. ठीक है. So important is ट्रैली. अगर मैं बात करता हूँ ट्रैली की, what is ट्रैली? Transfusion related acute lung injury. सर्जरी में पढ़ाया हुआ है. ये बताओ मुझे, चेस्ट एक्सरे नंबर 1 और चेस्ट एक्सरे नंबर 2 इज ऑफ ट्रैली, कौन सा है? 2 वाले हाथ उठाओ, 1 वाले हाथ उठाओ. तुम दोनों किसी पाले में नहीं हो क्या? 1 वाले हाथ उठाओ. चलो 2 वाले. अभी तक 2 बोल रहे थे, वो कहाँ गायब हो गए? 2 है 1 है? 2 है 1 है? 2 है 1 है? बेसिक डिफरेंस क्या है? चलो 2 में क्या दिख रहा है? क्यूब नहीं बोला. चलो तुक्के नहीं मारने, मेरे को लॉजिक चाहिए. मैंने लॉजिक बताया हुआ है क्लास में. वेरी गुड. द कार्डियोथोरेसिक शैडो इज मोर. अगर कार्डियोथोरेसिक शैडो इज हाई, दैट मींस देयर इज कार्डियक एनलार्जमेंट. अगर कार्डियक एनलार्जमेंट है, दैट मींस द हार्ट इज सफरिंग फ्रॉम कंजेस्टिव हार्ट फेलियर, एंड ड्यू टू कंजेस्टिव हार्ट फेलियर the blood is not able to pump. Okay, and as the blood is not able to pump, तो पूरा का पूरा blood कहाँ रह जाता है? lungs में. and पूरा का पूरा blood जब lungs में रह जाता है, the patient develops pulmonary edema. But this is cardiogenic or non-cardiogenic pulmonary edema? Cardiogenic. क्यों? Because it is occurring due to heart failure. Heart failure है, इसलिए the patient develops pulmonary edema ना बच्चों. So this is a cardiogenic pulmonary edema. कौन सा sign दिखता है classical? Bat wing appearance. Cardiogenic pulmonary edema में we get the characteristic bat wing appearance which is not seen in a non-cardiogenic pulmonary edema. Important is that. ठीक है. और दूसरा difference क्या बताया था? Anybody to differentiate this X-ray from TRALI? X-ray नहीं, to differentiate this condition from TRALI. Very good. Very good. BNP levels. BNP is brain type natriuretic peptide. कब release होता है वो? Only in cases of heart failure. So if BNP levels are high and cardiothoracic ratio is more, it is a case of cardiogenic pulmonary edema. Usually, I say the patient has been given massive blood transfusion, after which the patient is having cardiogenic pulmonary edema. That is the case of TACO, transfusion associated circulatory overload. ठीक है? And whereas if I say, can you see the cardiothoracic ratio is normal? Only you are able to see patches in the lungs, na? They are due to pulmonary edema. Okay, so this is the case of cardiogenic or non-cardiogenic? This is the case of non-cardiogenic pulmonary edema. And non-cardiogenic pulmonary edema mein, the levels of BNP will be normal or high? The levels of BNP will be normal. Okay, so this is the case of TRALI, that is transfusion related acute lung injury. Here also they will give a history of massive blood transfusion. ठीक है, तो massive blood transfusion के बाद दोनों हो सकता है, मैं देखना है एक्सरे और BNP लेवल. ठीक है, चलो. Any which ways we were not able to see any BNP levels also over here, and any which ways TRALI में कोई पेटिकी वेटिकी कुछ नहीं होता है. Only the patient has respiratory symptoms again. Question number 163. A 40-year-old patient was brought to the emergency after a road traffic accident with knee swelling and tenderness. Okay. X-ray is given below. What is the appropriate management? So, what does this X-ray suggest you of in the knee? It is the suggestion of fracture of patella. Displaced or undisplaced fracture? Displaced, rather comminuted fracture of patella. Comminuted मतलब टुकड़ों में बढ़ गया patella. ठीक है? So it is a displaced comminuted fracture of patella. And we know अगर patella को साथ में लाना है तो क्या करना पड़ेगा? We need to apply compression forces. Okay, we need to apply compression forces, for example, and that compression forces will be done by wiring. Okay, so that is what is done. Tension band wiring, it is called as TBW. Okay, it is known as TBW, tension band wiring. It is open reduction and internal fixation with tension band wiring. No issues with this, anybody? So that is important. If there is an undisplaced fracture of patella, what can be done? अनडिस्प्लेस्ड है ना, ये डिस्प्लेस में ऑपरेट करोगे, अनडिस्प्लेस्ड में भी खोलोगे क्या पेशेंट को? बराबर, कास्ट, ओके, यू विल अप्लाई अ सिलेंड्रिकल कास्ट, यू कैन अप्लाई सिलेंड्रिकल कास्ट, अनडिस्प्लेस्ड है ना, पटेला बस फ्रैक्चर्ड अभी भी ऐसा ही है, तो फालतू में क्यों तुम्हें सर्जरी करनी है बाद में? Just apply a class, just go for immobilization. It will heal by its own. Give it time. That's it. Undisplaced fractures may we don't go for surgeries unless and until there are high chances of non-union or malunion. We don't. Okay? So that's the basic idea. Please remember, this was recent NEET PG question 2022. क्या दिख रहा है ये? कौन सा fixator है? Very good. External spanning fixator. And ये question था, external spanning fixator तो है, but उसके साथ साथ दूसरा ये भी था कि it is done for which fracture? It is done for periarticular fracture. It is done for periarticular fracture. Articulation is what? Joint. तो knee joint के आसपास जो fracture होगा उसके लिए किया जाता है. Okay? So any fracture over here in this area, periarticular fracture के लिए we will go for this external spanning fixator. Because याद रखना, कभी भी तुम जहां पे फ्रैक्चर है वहां पे इमोबिलाइज नहीं करते हो. वन जॉइंट अबव, वन जॉइंट बिलो इज द रूल ऑफ फिक्सेशन और इमोबिलाइजेशन. वन जॉइंट अबव, वन जॉइंट बिलो. ठीक है, दैट इज व्हाट इज fixation is done. Next is, what is this fixator known as? Ilias-Zorro's ring fixator. Ilias-Zorro's ring fixator is used for, it is used for limb lengthening procedure. अगर एक limb छोटी हो, definitely for limb lengthening procedure, it is based on the principle of distraction, osteogenesis. That means हर रोज थोड़ा थोड़ा गैप बढ़ाओगे, कितना? 1 mm. ठीक है, 1 mm का गैप बढ़ाते हो. No issues with this. That is the Ilias-Zorro's ring fixator. Question number 164. A child with a recent history of fever, pain and tenderness at upper part of the tibia. ठीक है? Since 2 weeks. X-ray taken is given below. Identify the diagnosis. Child with fever, pain and tenderness in the bone. Fever, pain are signs of inflammation. So definitely there is inflammation, and that inflammation is due to infection. Right? So there is bone infection over here. And bone infection is known as osteomyelitis. As there is osteomyelitis, you can see they have given, it is the upper part of tibia जहाँ पे दिख रहा है एक lesion. Okay, that is a black colored or osteolytic lesion. Okay, and can you see around that osteolytic lesion there is a white color margin. This is nothing but a sclerotic margin. Sclerotic margin क्यों बनी है? Anybody? The child is immunocompetent or immunocompromised? He is immunocompetent. That means his immunity is strong. Therefore, the infection has not spread. पहले ही उसको कंट्रोल कर लिया गया with the help of this formation of a sclerotic ring around the infection. ठीक है? So if there is sclerosis around the infection, that is suggestive of immunocompetent patient, that is strong immunity or good immunity. ठीक है? So this is a case of, it cannot be chronic क्योंकि infection आगे फैल ही नहीं सकता. So it is a case of subacute osteomyelitis, and this is classically called as which abscess? Anybody? Brody's abscess. Either they will mention it in this format, it is known as Brody's abscess, or it can be a case of subacute osteomyelitis. It can be a case of subacute osteomyelitis. Please remember that. No issues with this, anybody? Synovitis. Synovium होता कहाँ पे है? Joint में. Synovium is present in the joint. And if there is inflammation of the synovium, that is synovitis, is nothing else but inflammation in the joint itself. And that is the reason why here the patient will present with fever, the patient can present with pain, but the patient will have a painful limp. Langda ke chalega usually. That is the classical feature of synovitis. Okay. So any type of arthritis, any type of synovitis, the patient will have a painful limp usually. Okay. So that is a characteristic feature. Chronic osteomyelitis is not like seen with Brody's abscess. Chronic osteomyelitis में क्या होता है? So usually there are three important features. Hallmark, अगर मैं clinical hallmark पूछूं, clinical hallmark अगर मैं पूछता हूँ, clinical हाँ, तो you are right all of you. That is a sinus formation. And उस sinus से क्या बाहर आता है? Pus. ठीक है? तो clinical hallmark, that means you are able to see the sinus and pus is draining out of that sinus. That is the clinical hallmark. But if I ask you about the radiological hallmark, which was the previous year question, very good. The radiological hallmark is a sequestrum. Okay, so the radiological hallmark. Hallmark is a characteristic feature. So the radiological hallmark is a sequestrum. Sequestrum is nothing but this dead necrotic bone. The dead necrotic bone is called as a sequestrum. अब dead bone है तो उसके आसपास नया bone बनना शुरू हो जाएगा. That new bone formation is called as involucrum. That new bone formation will be called as involucrum. And usually pus कहाँ बन रहा है bone के अंदर, वो बाहर कैसे आ रहा है with the help of sinus, but bone से भी तो बाहर आना चाहिए, तो bone से जो बाहर आता है that is what with the help of cloaca. Skin से बाहर आएगा with the help of sinus, but bone से बाहर आएगा with the help of cloaca. ठीक है? So what is the clinical hallmark? Sinus. Radiological hallmark? Sequestrum. Dead necrotic bone is known as sequestrum. New bone is known as involucrum. The for pus drainage on skin we have the sinus. For pus drainage in bone we have the cloaca. कोई दिक्कत नहीं है. That's it. ठीक है? ट्रीटमेंट क्या करते हो बताओ? एंटीबायोटिक्स तो दोगे ही ना. सुनाइए. सॉसराइजेशन करते हो ना? It is excision only, but that is saucerization. Saucer जैसे निकालते हो, ठीक है? You need to cut it like a saucer. ठीक है? That is known as saucerization, which is done in case of chronic osteomyelitis. What is the most common cause of acute osteomyelitis? Anybody? Staph aureus. What is the most common cause of acute osteomyelitis in a patient of IV drug abuser? IV drug abusers. Staph aureus. ठीक है? Overall also staph aureus. IV drug abusers also staph aureus. Important. Most common cause of acute osteomyelitis in a patient of hemoglobinopathy. Sickle cell anemia, thalassemia. Very good. It is salmonella. This was a previous year question. In a case of hemoglobinopathy, the most common cause of osteomyelitis, ये question भी करवाया मैंने, that is salmonella. Okay, please remember that. No issues with this, anybody? So that's the important thing you need to be aware of. Question number 165. A child was brought with the below given deformity. On history taking, parents revealed that the child has sustained a fracture a year ago and a cast was applied for the same. What is the likely cause of this deformity? What is the fracture? What is the fracture? It is the fracture which is supracondylar fracture of humerus. Supracondylar fracture of humerus is a intra-articular fracture or an extra-articular fracture? It is a extra-articular fracture. Shabash. So if it is an extra-articular fracture, there will be high chances of malunion or non-union. There are high chances of malunion. So non-union के high chances कहाँ होते हैं? Intra-articular fracture. In cases of intra-articular fracture, the fracture within a joint, there will be high chances of non-union. There will be high chances of non-union. Non-union कब बोलते हो? When callus formation, normal callus formation takes place. ये question था. Callus formation starts at end of 3 weeks. Callus formation starts at end of 3 weeks. What is callus? Immature bone. Callus is nothing but a immature bone. It starts at the end of 3 weeks after fracture and completes by 3 months usually. But if the callus is not formed for more than 6 months, that is called as delayed union. If the callus is not formed for more than 6 months, that is called as delayed union. And if the callus is not formed for more than 9 months, that is called as non-union. Okay, यहाँ तो fracture जुड़ ही नहीं रहा. अगर fracture जुड़ता है but गलत जुड़ जाता है, that is what is called as malunion. And due to malunion, the patient will have deformity. ठीक है? In cases of supracondylar fracture of humerus, this classical deformity is seen. Cubitus varus or cubitus valgus? Varus या valgus? It is a cubitus varus deformity. So this cubitus varus deformity which is there, okay, is also known as which deformity? Gun stock deformity. So this is known as the gun stock deformity. The answer to this question will be option number B, malunion of supracondylar fracture. Lateral condylar fracture mein there will be high chances of non-union because it is an intra-articular fracture and the 3-point bony relationship between medial epicondyle, lateral epicondyle and the olecranon will be disturbed in lateral condylar fracture. No issues with this, anybody? Olecranon fracture treatment batao jaldi se. Very good. Tension band wiring. Not only patella, you need to remember olecranon also. Okay? Olecranon fracture may be the treatment of choices, tension band wiring itself. NEET-PG ka previous year question reh chuka. No issues with this, anybody? That's important. Now, please tell me the fractures of necessity. Dr. Mukul would have told you. Fractures of necessity. All the intra-articular fractures. Fractures of necessity matlab the fractures which will require management always and always by or if open reduction and internal fixation. Closed reduction cannot be done for fractures of necessity. Jaldi say first are intra-articular fracture. Second are very good fracture of forearm, that is Galeazzi and Monteggia fracture, Galeazzi and Monteggia fracture. अभी बोला जिसमें हाई चांसेस हो सकते हैं नॉन यूनियन के, अभी तो बोला यार, lateral condylar fracture of humerus, lateral condylar fracture of humerus, और if करते हैं इसमें अपन इंट्रा आर्टिकुलर, हाँ इंट्रा आर्टिकुलर, बट स्पेसिफिकली वी विल मेंशन दैट. ठीक है, नो इश्यूज विद दिस एनीबॉडी, दैट्स इंपॉर्टेंट. नेक्स्ट क्वेश्चन नंबर 166. A 53-year-old female presented with complaints of knee joint pain for the last 6 months. She adds that pain exacerbates whenever she sits after her household work usually. ठीक है, non-examination swelling is noted around the knee joint and arthrocentesis reveals needle-shaped crystals with negative birefringence. What is the likely diagnosis? Female who is having knee joint pain. Okay, pain exacerbates usually and sitting. Swelling is noted. So swelling and pain are suggestive of inflammation. So definitely there is inflammation of the joint. Okay, and which joint? Knee joint. Arthrocentesis. मतलब क्या? Insert a needle in the knee. Insert a needle in the joint. Aspirate the synovial fluid and send it for examination. On examination, it is seen that crystals are seen. Which shaped crystals? Needle shaped crystals. एक तो नीडल शेप दिख सकते हैं, दूसरे रोम्बॉइड क्रिस्टल्स दिख सकते हैं. ठीक है, नेक्स्ट एक तो नेगेटिव और पोलराइज्ड माइक्रोस्कोपी पे क्या दिख रहा है? नेगेटिव बायोफ्रिंजेंस दिख रहा है. एक तो नेगेटिव बायोफ्रिंजेंस दिख सकता है या दूसरा वीक पॉजिटिव बायोफ्रिंजेंस दिख सकता है. ठीक है, नाउ अगर नीडल शेप क्रिस्टल्स दिख रहे हो और नेगेटिव बायोफ्रिंजेंस हो, दीज आर विच क्रिस्टल्स एनीबॉडी? These are which crystals anybody? These are monosodium urate crystals. And agar rhomboid crystals with weak birefringence दिख रहा हो, these are which crystals anybody? शाबाश. These are CPPD crystals, that is calcium pyrophosphate dihydrate crystals usually. ठीक है, so if monosodium urate crystals are seen, that is the case of gout, and CPPD crystals are seen, that is the case of pseudo gout. So gout is not only MTP joint ना, ये recent FMG question, हमें भी नहीं दिया, नीट पीजी में भी नहीं, वो रिसेंट एफएमजी क्वेश्चन. तो याद रखना है कि बस एमटीपी जॉइंट है ग्रेट तो रट के गाउट नहीं पढ़ा जाता. Gout can occur anywhere in the body because there is hyperuricemia, excess of uric acid in the body that can deposit in any joint of the body. Less commonly the larger joints, but larger joints can be involved. यही बताना था उनको, इसीलिए they have given this question. Larger joints can also be involved in gout. More important, अगर तुम्हारे पास ये लिखा है, तुम इन्वेस्टिगेशन पे जाओगे या जॉइंट इन्वॉल्वमेंट पे जाओगे? इन्वेस्टिगेशन पे भरोसा करोगे ना यार. नीडल शेप क्रिस्टल्स, नेगेटिव बायोफ्रिंजेंस, व्हाट इज मोर इंपॉर्टेंट देन दैट? इट शोज मोनोसोडियम यूरेट क्रिस्टल्स, दैट इज सजेस्टिव ऑफ गाउट इटसेल्फ. If they would have said rhomboid crystals with weak positive birefringence, then that can be a CPPD crystals of pseudo gout. Na? Yes, I know in pseudo gout, most common joint involved is the knee joint, but that does not mean that gout cannot occur in the knee joint. Na? So that's the basic idea. That was the gout. Recent FMG question. Don't make a mistake again if this question appears in your exam. Please remember this. Okay? Rheumatoid arthritis, small joints or large joints? Small joints. Young female or elderly female? Bilaterally symmetrical or asymmetrical? Bilaterally symmetrical. मतलब इस हाथ में दर्द हो रहा है तो इस हाथ में भी दर्द होगा. Which joint is paired? DIP. That is a distal interphalangeal joint usually. It is also associated with morning stiffness. Morning stiffness for less than 30 minutes. Ankylosing spondylitis, morning stiffness for more than 30 minutes. Rheumatoid arthritis usually. ठीक है? And the pain exacerbates with work or improves with work? Improves with work or improves with activity. Okay, drug of choice for rheumatoid arthritis, DMARD. The drug of choice will be, DMARD of choice will be methotrexate. DMARD of choice in pregnancy, hydroxychloroquine. Investigation of choice for rheumatoid arthritis, anti-CCP, cyclic citrulline peptide antibody. Screening test, RA factor. और क्या चाहिए? बस इतना ही देखना होता है. हाँ. Negative birefringence usually, it will not glow. On polarized microscopy, the crystals usually glow. Okay, if they glow, that is called as positive birefringence. If they do not glow, that is called as negative birefringence usually. Okay, so that's the important. Osteoarthritis is seen in elderly patients, but important is in osteoarthritis, it is seen in elderly patient. The most common joint involved is the knee joint, but important is in that patient, there will not be any kind of crystals which will be deposited. Okay, there will not be any kind of crystals in the osteoarthritis. Osteoarthritis में क्या होता है? Friction between the two bony surfaces. Okay, apart from that, there is narrowing of the joint space. Very good. And important, most important, there can be loose bones which are there. Okay, these are called as osteophytes. that osteophytes can develop in cases of osteoarthritis. It will never be any crystals. Okay, so that's the basic idea. Osteoarthritis can be symmetrical, can be asymmetrical. Okay, rheumatoid is always symmetrical. Question number 167. A 60-year-old woman with history of Colles fracture. Now, important is elderly patients में Colles fracture ज़्यादा common क्यों है? Estrogen कम होता है. That is post-menopausal female. And estrogen कम होता है तो क्या होता है patient में? Osteoporosis. So post-menopausal osteoporotic females में there are multiple fractures which are common. जल्दी से बताओ. Usually Colles fracture occur when which kind of injury occurs in the patient? Push injury. That is fall on an outstretched hand. जल्दी से बताओ. Push injury अगर होती है, which is the most common fracture in children? Shabash. It is the supracondylar fracture of humerus, which is the most common fracture in adults or adolescents. Very good. It is the scaphoid fracture, and which is the most common fracture in elderly osteoporotic patients? It is the Colles. Okay? So this will help you make your diagnosis much easier if you know this. Okay? So push injury mention किए, age group देखो and think in terms of these fractures first. Okay? So they have mentioned about Colles fracture 8 months ago, and she has attained a menopause at the age of 52. That means she's post-menopausal only. Comes with a T-score of -2.5 on a DEXA scan. What is DEXA? Dual energy X-ray absorptiometry scan, which is the investigation of choice for osteoporosis. If the value is more than -1.5, that is suggestive of normal bones. Okay, if the value is between -1 to -2.5, that is suggestive of osteopenia. Important. Okay, and when the value is less than -2.5, that is suggestive of osteoporosis. Please remember that. Okay. So osteoporosis हो चुका है patient में because she is having a score of -2.5. And osteoporosis is the most common cause of which type of fractures? Anybody? Pathological fracture. Pathological fractures occur in normal bone or osteoporotic bone? Osteoporotic. ठीक है? याद रखना, most common cause of pathological fracture is osteoporosis. Please remember that. ठीक है? But she is currently asymptomatic. Her serum calcium and phosphate levels are also normal. What is the most appropriate treatment? क्या करोगे? मैंने पहली बार सुना है कि ऑस्टियोपोरोसिस के लिए हार्मोन रिप्लेसमेंट थेरेपी देते हैं अपन. पेशेंट ऑर्थो वाले के पास गए या ऑब्स वाले के पास गए? ऑर्थो वाला हार्मोन रिप्लेसमेंट थेरेपी स्टार्ट करेगा क्या? Start alendronate strat. Drug of choice for any reason of osteoporosis. Answer is directly bisphosphonate, alendronate. Any cause of osteoporosis, drug of choice directly bisphosphonate. ठीक है, तो please remember that. Bisphosphonates are dronate kind of drugs. Alendronate, zoledronate, trazodronate. Sorry, zoledronate is the longest acting agent which is required once every year itself. Once every year. Okay, that is zoledronate. Please remember. And what is the most common side effect of bisphosphonates? Most common side effect of bisphosphonates. अरे क्वेश्चन था रे प्रीवियस ईयर. हाँ, हॉट फ्लैशेस वो एस्ट्रोजन को थोड़ी बढ़ा रहा है यार. क्या? It is esophagitis. Therefore, what is the advice that you give? ये कमेंट्स बंद हो जाने चाहिए यहाँ पे. आधे तो उधर देख के आंसर कर रहे हो. Esophagitis important. So that does not mean कि याद रख लो कि ये किसी को नहीं पता, उधर पता है. ठीक है, so that is important. Esophagitis इसलिए इंपॉर्टेंट है, और वो हर एक सब्जेक्ट नहीं खोल के बैठ सकते कि मैं जो क्वेश्चन बोलूं उसका देख के आंसर बता रहे हूँ. तो इसीलिए इंपॉर्टेंट है esophagitis. Please remember esophagitis की वजह से what is the advice that we give after bisphosphonate? That was a recent NEET-PG question. Usually take it on full stomach or empty stomach? Empty stomach. Take it with full glass of water and do not lie after at least for 30 minutes after taking the drug. That is the most important advices that you give in a case of bisphosphonate drug. Please remember that. No issues with this. कैल्शियम एंड विटामिन डी सप्लीमेंटेशन विल बी स्टार्टेड, बट दैट इज अडजंक्ट थेरेपी, मतलब साथ में देते हैं, इट इज नॉट द फर्स्ट लाइन ऑफ मैनेजमेंट, ठीक है, प्लीज रिमेंबर। और यहाँ पे तुम बोलोगे सर इसको तो सिम्टम भी नहीं है, कैल्शियम फॉस्फेट नॉर्मल है, भाई उसका 2.5 है, -2.5 ऑलरेडी आ चुका है, दैट मीन शी इज इन ऑस्टियोपोरोसिस। अगर तुम और थोड़ा देर रुकते हो, कैल्शियम 1 फॉस्फेट नॉर्मल क्यों है बताओ, ऑस्टियोपोरोसिस का पेशेंट है ना, पैराथ हार्मोन बढ़ गया, वो और बोन को तोड़ रहा है, तो तुम्हें लग रहा है कि कैल्शियम फॉस्फेट नॉर्मल, इससे कुछ देने की जरूरत नहीं है। हाँ। हम्म। हाँ, तो एज ग्रुप के हिसाब से बिस्फॉस्फोनेट्स देते हैं। इंपॉर्टेंट है, अगर स्कोर कम हो तो यू कैन गिव इट इवन टू एल्डर, इवन टू ए यंग पेशेंट ऑल्सो, क्योंकि बिस्फॉस्फोनेट जैसा मैजिकल इफेक्ट और किसी के साथ हो ही नहीं सकता है, बेसिक है, क्योंकि बिस्फॉस्फोनेट्स आर नोन टू इंक्रीज द बोन मिनरलाइजेशन। कैल्शियम और विटामिन डी देते रहोगे, क्या मतलब है उसका? इंपॉर्टेंट है, अगर स्कोर कम हो तो, यहाँ पे स्कोर डायरेक्टली दिया हुआ है, अगर तुम्हारे क्वेश्चन में कुछ नहीं मेंशन होगा, तुम हमेशा ये देखो कि सर का क्वेश्चन अलग होगा, मेरा क्वेश्चन अलग है, सर के क्वेश्चन में डेक्सा स्कोर मेंशन नहीं होगा, देयरफॉर उन्होंने मेंशन किया होगा, समझ रहे हो? जब तक स्कोर मेंशन नहीं है तब तक तुम कैल्शियम और विटामिन डी देते रहोगे, जैसे ही स्कोर मेंशन हो जाता है मतलब इट्स श्योर शॉर्ट डायग्नोसिस ऑफ ऑस्टियोपोरोसिस ना भाई। तो अगर श्योर शॉर्ट डायग्नोसिस है तुम्हारे पास तो कैल्शियम और विटामिन डी पे चलते रहोगे क्या? नहीं ना, तब तो ड्रग ऑफ चॉइस देना ही पड़ेगा। हम्म। तब तुम स्टार्ट इनिशियली विद कैल्शियम एंड विटामिन डी कर सकते हो, बट अगर डेक्सा स्कोर दिया है, इट इज अ डायग्नोस्ड केस ऑफ ऑस्टियोपोरोसिस, देन डेफिनेटली यू हैव टू स्टार्ट एलेंड्रोनेट, अदरवाइज द पेशेंट विल, याद रखना, द पेशेंट विल सफर वर्टिब्रल फ्रैक्चर्स, पेशेंट विल सफर वर्टिब्रल फ्रैक्चर्स, एंड अगर हो जाता है तो पेशेंट का आउटकम बहुत बुरा होगा। हार्मोनल थेरेपी इंडिया में दी ही नहीं जाती है, बेसिक, वो हार्मोनल थेरेपी तुम पढ़ते हो, हार्मोनल थेरेपी कोई नहीं देता इंडिया में। कौन देता? कौन सी फीमेल हार्मोन रिप्लेसमेंट थेरेपी ले रही है? अपनी मॉम को, मासी को फोन करके पूछना आप एचआरटी लेते हो क्या। इंपॉर्टेंट, इंडिया में हार्मोन रिप्लेसमेंट थेरेपी देते ही नहीं है, प्रसन्न सर ने खुद बताया होगा ना, एचआरटी इंडिया में देते ही नहीं है भाई, एचआरटी प्रेफर ही नहीं करी जाती इंडिया में। और बाय द वे बेसिक है यार एचआरटी, ऑर्थो वाला एचआरटी देगा क्या ये बताओ मुझे? बेसिक, बेसिक है यार, अगर एचआरटी ऑर्थो वाला देता ही नहीं है तो तुम एचआरटी स्टार्ट करोगे, बट एडजंक्ट थेरेपी है ना वो, बेसिक है। और एचआरटी के साइड इफेक्ट्स नहीं होंगे क्या, बताओ मुझे? हाँ, मतलब मैं वही बोल रहा हूँ, एचआरटी के साइड इफेक्ट नहीं होंगे क्या? 10 साइड इफेक्ट है एचआरटी के, तो तुम्हें सेफर ड्रग कौन सी, एलेंड्रोनेट या एचआरटी? इसलिए एलेंड्रोनेट स्टार्ट करते हैं। इंपॉर्टेंट है, एलेंड्रोनेट 3 साल से ज्यादा नहीं देते अपन, मैं ये नहीं बोल रहा हूँ कि लाइफ लॉन्ग चलेगी, बट 3 साल से ज्यादा नहीं देनी है, बट एलेंड्रोनिन के साथ जो इफेक्ट होता है वो एस्ट्रोजन के साथ नहीं दिख सकता, दैट्स द बेसिक थिंग। दोनों सब्जेक्ट को कंबाइन मत करो प्लीज, दोनों सब्जेक्ट अलग है। पेशेंट 60 साल का अगर इंसान होता है, एचआरटी देते उसमें, तो अगर एज और सेक्स को बाजू में रखो तुम, बेसिक ड्रग ऑफ चॉइस फॉर ऑस्टियोपोरोसिस ऑफ एनी रीजन, बिसफॉस्फोनेट्स ना भाई, दैट्स द इंपॉर्टेंट थिंग। एंड ऑस्टियोपोरोसिस में मोस्ट कॉमन फ्रैक्चर्स आर वर्टिब्रल फ्रैक्चर, स्पाइन फ्रैक्चर्स होते हैं, ठीक है, वर्टिब्रल फ्रैक्चर्स आर यूजुअली मोस्ट कॉमन। इंपॉर्टेंट इज, क्या दिखता है यूजुअली, कौन से टाइप का वर्टिब्रा दिखता है? कॉर्ड फिश और फिश माउथ वर्टिब्रा, कॉर्ड फिश और फिश माउथ वर्टिब्रा इज यूजुअली सीन ऑन एक्स-रे और even on a CT scan, please remember that, no issues with this. Question number 168, it states a patient was asked to stand on his left leg and his right hip falls down, which among the following muscles will be affected in this case? What is this test performed? This test is known as the Trendelenburg test. If I talk about the Trendelenburg test, please remember, क्या करते हो? You ask the patient to lift one of the legs. तो यहाँ पे patient कौन सा leg उठा रहा है? He is lifting up the left leg. But can you see the hip is falling down on one side? No. That means this is a normal patient. तुम अपना एक पैर उठा लेते हो, तुम्हारी हिप एक तरफ गिरती है क्या? नहीं गिरती ना, that means it is normal. Please remember, क्यों? Because these muscles on the opposite side, what are these muscles on the opposite side? The hip abductors, gluteus medius and gluteus minimus, they are known to maintain this pelvic axis, they will contract, okay, and they will maintain this pelvic axis, please remember, but on the opposite side. अगर तुम लेफ्ट लेग उठा रहे हो मतलब कौन सी मसल्स कॉन्ट्रैक्ट हो रही है? राइट gluteus medius and right gluteus minimus contract hoti hai and they maintain the pelvic axis. But now in this case, you are lifting which leg? Left leg, and the pelvis is drooping down on left side. As the pelvis is drooping down on left side, that means कौन सी muscles weak है तुम्हारी? Right sided gluteus medius and right sided gluteus minimus. And gluteus medius and gluteus minimus जो होती है definitely both are innervated by. Voice is not heard. I hope now the voice will be fine. So the gluteus medius and gluteus minimus both are innervated by which nerve? Anybody? Very good. They are innervated by the superior gluteal nerve. In superior gluteal nerve injury, definitely there will be weakness or there will be palsy of gluteus medius and gluteus minimus. Whereas gluteus maximus is supplied by inferior gluteal nerve. यहाँ पे important कौन सी muscles है? Gluteus medius and minimus. So Trendelenburg test tells you about the function of gluteus medius and gluteus minimus on the same side or opposite side? Opposite side usually. Okay, and also tells you about the function of which nerve? Superior gluteal nerve. तो अभी इस patient में क्या हो रहा है? He is standing on his left leg and his right hip has fallen down. मतलब उसने right leg उठाया और right side में pelvis नीचे जा रही है. ठीक है? So definitely which sided muscles are weak? If right hip is falling down, matlab his left sided muscles are weak. Left sided which muscles? Left gluteus minimus and left gluteus medius muscles are weak. No issues with this, anybody? Remember this, ठीक है? Question number 169. So 170 तो कर लो फिर ले लो. Question number 169. A 5-year-old child presented with edema for the last few months. It started on face. Okay, there was a facial edema in the child, but now it is generalized with pedal edema and there is also ascites. मतलब diffuse edema throughout the body. Generalized edema is known as, very good, anasarca. So they will mention it in the question. Don't get confused. What is anasarca? Anasarca is nothing but generalized edema of the body. He showed good response to steroids. Okay, his RBS was 1112 milligrams per deciliter. Urine examination reveals massive proteinuria. Massive का मतलब कितना होता है? More than 3.5 grams per day. That is also called as which range proteinuria? Nephritic or nephrotic? So it is definitely nephrotic range proteinuria. ठीक है? तो please remember that. On light microscopy, the findings was unremarkable. Unremarkable का मतलब क्या होता है? Absolutely normal. Nothing is seen on light microscopy. On electron microscopy, the kidney biopsy shows effacement of podocytes. Effacement of podocytes is seen in two conditions. One is minimal change disease. Second is FSGS. Important. FSGS occurs in elderly or children. Most common cause of nephrotic syndrome in adult patient is usually FSGS. Most common cause of nephrotic syndrome in children is definitely MCD. That is nothing but minimal change disease. Identify the given condition. It is A, minimal change disease. याद रखना, what are the essential criteria for diagnosis of nephrotic and nephritic, guys? Nephrotic सबसे पहले, more than 3.5 grams per day of protein urea. Second feature, which protein is predominantly lost over here? Albumin. So that will cause hypoalbuminemia. And अगर albumin lost होता है, all the fluid will go outside due to decreased plasma oncotic pressure, and that will lead to edema. So these are the classical three features, essential features of nephrotic syndrome. इसके साथ साथ hypertension, lipiduria, lipidemia हो सकता है, but those are not diagnostic. These three are diagnostic features, definitely. Please remember. ठीक है? Most common cause of nephrotic syndrome in adults, FSGS. Children, MCD. Elderly, membranous glomerulonephritis or membranous nephropathy, whatever you call it. No issues with this. If I talk about nephritic syndrome के तीन features क्या क्या होते हैं? There is proteinuria again, but proteinuria less than 3.5 grams per day. Second, hypertension, and third, hematuria. Most common cause of nephritic syndrome in adults, IgA nephropathy, also known as Buerger's disease. Most common cause of nephritic syndrome in children, PSGN, post-streptococcal glomerulonephritis. That's important. Okay, light microscopy shows no changes in cases of minimal change disease. इसीलिए उसको minimal change कहा जाता है. Okay, please remember. And electron microscopy only shows the changes. And what is seen on electron microscopy? Effacement of podocytes. Immunofluorescence shows what? Immunofluorescence MCD shows no deposits. Therefore, it is called as nil legion disease. Please remember that. ठीक है? What is the drug of choice? Steroids. Okay. Steroids start करते हो patient में. What is the drug? कौन से drugs देते हो यार? कौन सा steroid? Prednisolone ना. You will give prednisolone for a span of 6 to 8 weeks usually. ठीक है? You will give it for a span of 6 to 8 weeks usually. Long-term steroid. Therefore, the child can become immunocompromised. But if the child develops steroid toxicity, very good. Then you will give cyclophosphamide, or the other drugs which can be given are leflunomide or mycophenolate mofetil. But if the child is having, this was about steroid dependent nephrotic syndrome. दोनों में difference क्या होता है anybody? Steroid dependent nephrotic syndrome, that means जब तुम steroid देते हो, the patient's condition improves. That is the steroid dependent nephrotic syndrome. But okay, so in that condition you start with steroids, prednisolone. But if the patient is having toxicity, then you need to change for cyclophosphamide. If the patient is having steroid resistant nephrotic syndrome, then the drug of choice are calcineurin inhibitors, drugs like cyclosporin or tacrolimus. ठीक है, please remember that. FSGS के लिए भी drug of choice are steroids itself. Please remember. ठीक है? What is this anybody? क्या दिख रहा है किडनी बायोप्सी पे, लाइट माइक्रोस्कोपी पे? Crescent formation in the glomerulus. So this is the case of crescentic glomerulonephritis. Crescentic glomerulonephritis is also known as RPGN, rapidly progressive glomerulonephritis. They are of three types. Type 1 RPGN is known as good pasture syndrome. Which kind of deposits? Linear ribbon-like deposits, IgG and C3. Type 2 is known as immune complex mediated, IgA, PSG and SLE. Every type is type 2 RPGN itself. Type 3 RPGN is posse immune. It is the most common type of RPGN. Posse immune may definitely. The cause is vaginous granulomatosis, also known as nowadays granulomatosis with polyangiitis. Mark my words, vaginous option में नहीं होगा, because the term has been changed to granulomatosis with polyangiitis. तो सामने आंसर होगा, अगर पहचान नहीं पाए, it will be a mistake. Please remember, it is granulomatosis with polyangiitis. Start calling vaginous as GPA. ठीक है? So granulomatosis with polyangiitis. Over there, can you see any deposits? No deposits are seen in type 3 RPGN. Type 1 में linear deposits, type 2 में granular deposits, type 3 में no deposit. That's how you differentiate RPGN. ठीक है? That's important. What is this anybody? कौन सा appearance दिख रहा है ये? It is which appearance? Starry sky appearance seen in cases of PSGN. If a child is having, history of sore throat, okay, or impetigo, and 2 to 3 weeks later he presents with cola-colored urine, diagnosis is PSGN. If a patient is having history of sore throat or pharyngitis or impetigo, 2 to 3 days later he presents with hematuria, diagnosis is IgA nephropathy. तो दोनों में हिस्ट्री सोर थ्रोट या एम्पिटिको की होगी. 2 to 3 days later IgA, 2 to 3 weeks later PSGN. That's how you differentiate it. ठीक है? Age is not always a differentiating feature, क्योंकि IgA बच्चों में भी दिख सकता है, याद रखना ये बात. Question number 170. Which of the following is synergistic muscle of right lateral rectus muscle? So definitely for dextroversion, ठीक है? तो मूवमेंट में मदद करने वाला मसल होता है synergistic muscle. For example, I need to move my eyes towards the right side. Okay, इसमें मुझे जो मदद करेगा मसल, that is what is called as my synergistic muscle. जो opposite जाता है, that is called as a yoke muscle. The one which goes opposite is a yoke muscle. The one which helps is a synergistic muscle. Now dextroversion करना है. What is dextroversion? That is looking towards my right side. So for that, definitely, which muscle should constrict? Right lateral rectus. My right lateral rectus should constrict, right? For that, which muscle should be synergistic? Left medial rectus. क्योंकि अगर मुझे दोनों आंखों को राइट साइड में घुमाना है, इस तरफ की कौन सी मसल कॉन्ट्रैक्ट होनी चाहिए? राइट लैटरल रेक्टस. और इस तरफ की लेफ्ट मीडियल रेक्टस. सो द सिनर्जिस्टिक मसल विल बी लेफ्ट मीडियल रेक्टस. बेसिक फंडा याद रख लो. सिनर्जिस्टिक का मतलब होता है मदद करने वाली मसल. योक का मतलब होता है अपोजिट काम करने वाली मसल. तो सुपीरियर ऑब्लिक के लिए योक मसल विल बी inferior oblique ना. Medial rectus के लिए yoke muscle will be lateral rectus na. So that's how you need to remember this. ठीक है? So that's important. चलो एक break ले लो, then we'll meet after the break.